Good morning, everybody. It's 9 o'clock, and we start with a new appointment with pediatric leg surgery. You listen me?
Yes, Mario.
Okay. Okay. The program of today is a very complicated program because we have 4 surgical procedures. And I think that if Giovanna and Vito, that is the discussant, agree, a few minutes and we start, because we have 62 attended and we have 140 registered. It's okay, Giovanna and Vito?
Yes.
Yes, for me it's okay. Good morning to everybody. Thank you for inviting me to discuss this, follow this live meeting.
Thank you, Mario.
Okay.
I am ready. And
10 minutes, 10 minutes and we start. Okay. Good morning, all.
Good morning, Mario. Thanks again for inviting me. It's a pleasure. It's so honorable and so knowledgeable. I'm looking forward to another great day in Milano. Thank you.
Thank you.
Avanti. Qui, buongiorno. Ragazzi, sono in conference. Non ve lo posso parlare.
Libri, fai mostrare. Good morning, everybody. We are ready to start. Welcome to the 50th appointment of Pediatric Live Surgery. Today, the topic is the surgery and minimally invasive surgery of congenital cystic pulmonary disease. I hope that today's meeting is interesting and have the success of the previous one. Today, we have 140 registered participants. The operative theater of Bologna and Varese will be connected. And we also have connected the Pediatric Surgery Center in Siena, Pavia, Wrocław, Genova, Graz, and Luxembourg. The success of the meeting is also due to the participation of all of you with your questions. To participate, use the raise your hand function, please. Giovanna Ricci Pettitroni, Adrian Bianchi, and Vito Briganti will be discussant. I thank all my colleagues and friends for their help and collaboration. Without their help, it would be impossible to carry out this project. Now is the time to start. Please, Giovanna, if you want to start your, okay.
So good morning to everybody. Thank you again, Mario, and all the faculty to involve me in this very interesting meeting on mini-invasive surgery on congenital cystic pulmonary disease. I think we have to start with Bologna. Am I right, Mario, or not?
Yes.
Yes.
We are right. And we start with the show of preparation of operating table with Francesca. After, there is the position of the patients, of the first patients, and describe the clinical case. And after, the anesthesiologist describe the problems, anesthesiological problems for these patients that have a dysplasia, cystic dysplasia of the upper bowel. When you are ready, Vito, we connected with the operative theater of Bologna.
Thank you, Mario. The first presentation is preparation of an operative table for thoracoscopic procedure. Is nurse of Bologna, Francesca Martelli.
Francesca, you are ready?
Yes, you say me?
Yes, you.
Okay.
Yes, we are listening you very well. Good morning, Francesca. It's
Good
a pleasure
morning,
to
everybody.
hear from you.
Thank you.
Good morning, Francesca.
Everybody. I'm Francesca, and I tell you about the preparation of the operating table for this procedure of lung resection and pleurodesis. Surgical treatment can be performed with both thoracotomy and thoracoscopic access. I have prepared two operating tables, one for thoracoscopy and one for thoracotomy in case of conversion. Now I will show you the operating table for thoracoscopy. I will initially show you the instrument for the thoracic placement. From left to right, you can see knife with 11 blades useful to thoracoscopic surgery, pens, duval forceps, red-on forceps, and cockers. Curved, blunt, tissue scissors, short and long, and one suture thread scissors. 3 short surgical forceps, 2 the Beckey forceps, and 2 anatomic forceps. In this part of the table, I placed the retractors, 2 Farabeuf retractors, and 2 finger retractors, like this. Then with this instrumentation, the surgeon will place the 3 trocars, one 5 mm optical trocar with pneumatic anchoring for 5 mm 0-degree telescope. This. And one accessory trocar 5 mm non-reusable where instruments are used. And one accessory trocar 8 mm non-reusable where instruments are used. And where the surgeon can use the 8 mm stapler for resection. This trocar has an internal valve here that allows the surgeon to use the 5 mm instruments without losing the pneumothorax. If the resection requires the 12 mm stapler, another 12 mm trocar will likely be placed. This trocar has the same characteristics that allow to avoid the loss of the pneumothorax. Is here. here. Okay. At this point, I will show you the thoracoscopic instruments with a diameter of 5 millimeters and length 36 centimeters that I have placed in this part of the table. From left to right, you can see 2 grasping forceps fenestrated with especially final traumatic serration. 2 Redick-Hudson dissecting and grasping forceps, like this. 1 Kelly dissecting and grasping forceps, red-on forceps, here. 1 dissecting and grasping forceps with tiger jaws that the surgeon might use to perform pleurodesis before I show you. And 1 Mesenbach scissors, blunt and curved. 1 micro hook scissors. 1 coagulation and dissection unipolar electrode. And 2 Lima needle holders. This. Okay. A pistol grip for suction and irrigation. The peculiarity of these instruments is the possibility of being able to electrify them in this part of the handle, like this. Okay. The plastic handles are isolated and had a connector pin for unipolar coagulation with rackets and without rackets, like this. Okay, it's very important in our thoracoscopy procedure to have ready and functioning on the operating table coagulation, irrigation, and suction, always. Another instrument that can be used in this type of surgery is the reduction sleeve for the passage of the endoloops in case of need. These pieces of electrode cleaning sponge, that I have cut and that the surgeon will use to perform the pleurodesis. It is possible and use this instrument 8 millimeters and 25 centimeters called artisential endoscopic instrument to perform the pleurodesis. The double joint, like this, and this. Okay. Structure of the artisential allows the instrument to move with 360 degrees of freedom and provide control not available with the conventional laparoscopic instrument. As I explained earlier, the surgeon could also use these forceps, to mount pieces of electrode, like this, cleaning sponge, and do the pleurodesis. Now I show you the devices that could be used in this procedure. In another table, you can see the 12 millimeters trocar and mechanical stapler 12 millimeters with 8 millimeters reloads compatible, or 12 millimeters reloads. Here you can see ligature 5 millimeters and 37 centimeters Maryland tips, and here endoclip 5 millimeters 33 centimeters ready in case of need, always ready in operating room. And finally, I show you the endo bag 5 millimeters or 10 millimeters in case of based on the side of the piece. Okay. That's all. Thank you very much for your attention.
Thank you, Francesca. So I think you are organizing a 5mm procedure. I have a question for you. Do you think that sometimes the trocars are not too big, the head of the trocar for the thoracoscopic approach? What is your feeling as an expert in preparing an operative table?
For this patient, no, because it's very big. It's 14 years old, and the trocars are not much big.
The size of the patients is very big. And you have another question, Giovanna? Because he's already also the
Yes.
anesthesiologist.
No,
Yes.
I would like, I am very happy to hear from the anesthesiologist the experience.
Okay. Lorena, you are ready for to speak about. Okay. Michele, show the position of the patients, and after Lorena speak about the problems of these patients. Okay. Michele, you are ready?
We are ready? Okay. Okay. Buongiorno, good morning. Mi sentite? You listen me?
Good morning,
Yes,
Michele.
yes, yes,
We are
yes.
hearing you very well.
Ok, il mio inglese è un po' scarso.
Non ti preoccupare, Michele.
In italiano. Abbiamo posizionato il paziente su un fianco, mettendo una spezzatura sotto il torace in modo da esporre tutta la gabbia toracica, e con l'anestesista stiamo cercando di posizionare al meglio le braccia proprio per evitare lesione al plesso brachiale. E adesso abbiamo fissato fondamentalmente il paziente a livello del bacino, e adesso fisserò a livello della spalla, nella parte esterna, in modo da lasciare tutto il campo libero, comprendente il capezzolo e ovviamente dietro la colonna vertebrale. Il paziente aveva avuto un drenaggio perché ha fatto pneumotoraceo spontaneo, l'abbiamo rimosso qualche minuto fa, per cui vedete questo punto, e borsa di tabacco. E basta, direi che passo la parola alla dottoressa per tutta la parte che riguarda. Sì,
se posso
ci ho parlato io, ci parlo.
Ok. Posso parlare?
Non si sente nulla?
Ok. Buongiorno a tutti. Avete già visto che il nostro paziente di oggi è un paziente un pochino di una taglia diversa da quelle che facciamo di solito. È un ragazzo di 13 anni, pesa 85 kg e nella sua storia clinica c'è la storia di una miopatia in fase di studio, motivo per il quale per questo paziente abbiamo scelto di fare un'anestesia totalmente endovenosa. Stiamo facendo un'attiva con una TCI propofol e remifentanil, col propofol col target plasmatico, E dato che dobbiamo fare una toracoscopia, abbiamo utilizzato un tubo particolare, un tubo doppio lume, data appunto la taglia del paziente, che è un tubo che ci permette di, a 2 lumi, ci permette di vedere, di escludere il polmone dove andremo a fare la toracoscopia. La caratteristica del tubo, Edu mi sa che non si riesce più a vedere perché è rimasto qua sotto, è che ha una linea blu che ci identifica esattamente dove si trova nel bronco e una linea bianca che è quella della parte della porzione tracheale. La cosa fondamentale di questo tubo è che va esattamente controllato nel momento in cui si posiziona e va ricontrollato una volta fatta la posizione del paziente col fibroscopio, cosa che ci stiamo per accingere a fare perché ormai il paziente è nella posizione definitiva. Un'altra cosa fondamentale per questa tipologia di paziente è verificare con attenzione la posizione e la pressione della cuffia del tubo bronchiale per non fare dei danni sulla parete del bronco. Siccome pensiamo che questo paziente andrà in reparto e probabilmente non avrà neanche un drenaggio toracico al rientro del reparto, abbiamo fatto un blocco paramediano vertebrale, un erector spine block, utilizzando la guida ecografica. Abbiamo fatto un single shot utilizzando della levobupivacaina e riteniamo che con un minimo supporto di antinfiammatori e oppioidi possa essere sufficiente per controllare il dolore di questo paziente nel post-operatorio. Questo paziente aveva anche delle caratteristiche leggermente, una lieve ipoplasia della mandibola, per cui durante l'induzione abbiamo utilizzato anche il videolaringoscopio perché avevamo il sospetto che potesse essere un'intubazione difficile. In realtà era abbastanza agevole la laringoscopia. Il monitoraggio è un monitoraggio completo che comprende anche la SOS-line, il monitoraggio arterioso e quindi un monitoraggio completo. Abbiamo scelto, dato che il paziente è grande, di utilizzare solo 2 vie venose periferiche e non un accesso venoso centrale e direi che siamo quasi pronti per questo paziente. I prossimi pazienti invece saranno molto più piccini e quindi sarà un pochino più agevole per noi.
Thank you very much, Lorena. And now, Marco Dimitri, please, if you want present the clinical case of these patients.
Yes. 1 second. Okay. Do you see the presentation?
Yes, we see your laptop, please.
Okay. Good morning, everybody, and thank you, Professor Lima, for the presentation. I'm presenting a clinical case of an adolescent.
Non si usa più cloroprep.
Of 13 years old with a spontaneous pneumothorax that we are approaching through a thoracoscopy in order to perform a bullectomy and mechanical pleurodesis. So this patient was admitted in our emergency area for sudden chest pain, and no other significant information in an anamnesis was reported, except for a myopathy with non-clear definition. So we decided to perform a chest X-ray that showed us an important left pneumothorax, and we choose to recover the patients and place a chest tube, as you can see in this photo, in order to remove the area in the pleural space and provide the expansion of the lung. After 2 days, we performed the CT scan of the thorax, and this exam showed us almost complete resolution of the pneumothorax, but also some bubbles at the apex of both lungs. So this patient is going to be subjected to left apical bullectomy and mechanical pleurodesis. In the second time, we will perform the same procedure, but on the other side. Thank you for listening.
Thank you, Marco.
Vito, if you want to open the discussion, Giovanna. And now I go in the operative theater and I work with Michele Libri for the first cases. If you want, it's possible to start with the presentation. Giovanna, you have your presentation of the particular cases, if you want. Now yes. I go in the operative theater, and when we start with the position of of the trocar, I call you immediately.
Okay, thank you,
Okay.
Mario. So if I well understand, you prefer that I will start with my presentation. If you see, I have two computers connected because the presentation doesn't work in the institutional computer. So I move.
This is the festival of digital power of Giovanna.
I'm here. I am
Yes.
here. I think you can see me here anyway.
Yes, we
I
see
will
from
try-
Lord, is the laptop, this.
Yes, I changed my, just a minute. I have to open my presentation and live surgery. Okay, I try to open immediately. I have to say that I have 3 cases, which are really nice cases to be presented, in my opinion. Okay, there are some problems with this presentation. Okay, I will do it another way. I will present you any cases individually, because otherwise I will be in trouble. Okay, 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 okay. I try to share my screen. Just a minute, not in this way. Oh, why it's not possible to share for other people? Oh, I try to share. I can't see my files. Why? I have a problem with share computer sound. No, I don't know. Share. I can't see, I can't share my, I think I have to close this one. It's the only one.
Professoressa. Giovanna,
Sì?
lo vediamo bene? Vediamo il tuo computer già.
Sì, vedete il mio computer, ma io vorrei che voi vedeste la mia presentazione. Questo è il discorso. Invece,
non lo lancio.
Aspetta un attimo, provo a trovarla. Non la vedo, non vedo la maniera di lanciarla, questo è il problema. Per cui non so perché. You are cleaning, sharing, yes, ma è bello che lo faccio tutti i giorni, ma non ho capito perché non lo vuol vedere qua dentro. Provo a aprire la presentazione, vediamo se riesco a... non riesco a capire perché non vuole aprire. Ok. Voi vedete? Non credo.
Sì, sì, adesso vediamo.
Vedete la presentazione? Ok,
vediamo.
Allora non mi chiede di fare lo sharing, vuol dire che l'avete fatto o la regia l'ha fatto autonomamente. Ok, just a minute, perché adesso c'è questa roba qua in mezzo che mi disturba. Allora, questo è un primo, visto che oggi parliamo di adolescenti. Ore 15. Mi vedete, mi sentite?
Sì, Giovanna.
Ok,
sì.
perfetto. Visto che parliamo di adolescenti e Mario esordisce con un adolescente, mi fa molto piacere mostrarvi questo caso, che è un adolescente, un paziente di 16 anni, per dire che spesso hanno delle sorprese. Un ragazzo atletico che era stato etichettato come un possibile asmatico. In realtà nell'aprile 2021 questo ragazzo chiede una visita pneumologica urgente perché avverte la comparsa di episodi di dispnea, ma soprattutto come questi episodi di dispnea si associano anche a delle crisi ipotensive. Lui è uno sportivo, gioca a calcio e ha avuto delle crisi ipotensive con l'ipotimia, quindi qualcosa di veramente serio. Viene valutato dal punto di vista cardiologico, non viene ritrovato nulla di importante, dopodiché viene sottoposto a un attacco del torace. Qui ci sono le immagini senza contrasto in cui vedete che c'è un lobo inferiore sinistro che ha un aspetto decisamente patologico e oltretutto ha queste immagini, diciamo, queste strie, che non si capisce se sono vascolari o se sono bronchiali, nell'ambito, diciamo, anche della fase senza contrasto.
Giovanna?
Sì?
Sorry, if you can speak also in English.
Okay, excuse me. Excuse me very much. So I am very happy to show you this case of a 16 years old male who was considered an allergic patient affected by allergic asthma. Nevertheless, this patient in April 2021 have a worsening of his respiratory condition, and he has also some hypotensive attack during sports. So he went to in an emergency. He was evaluated. He was evaluated first of all for any cardiological disease. There was no cardiological affection. Then he was studied with a CT scan, and the previous phase of the CT scan was without contrast, but there was a different appearance, pathologic appearance of the inferior left pulmonary lobe. And then during the vascular phase, it was evident a sequestration, intralobar sequestration, with a big arterial vessel coming directly from the thoracic aorta. There was, if you look to this vessel, it's very big with all other big branches going inside the inferior lobe, and also while there was no modification of the venous drainage. So the final diagnosis was of intrapulmonary sequestration of the left lower lobe, with probably a sort of what we call the foot, a sort of which was responsible of calling too much blood into this lobe, and maybe under sport to determine, to produce the hypotensive and crisis. So we went to the surgery, and due to the age of the patient, according also to the experience of other colleagues such as Gentilino Valerio, who is with us today, we decided to do a Univats technique. It was the first experience that we have done, and we used we did a 3 millimeter incision, and we put the device and then the instrument inside the small device. Obviously, we used, as Mario today, big instrument, 10 millimeter thoracoscope 30 degree, and also 5 and 10 millimeter instrument for open surgery, and long instruments. I have to say I prefer to use 36, but also 42 centimeter long instruments due to the size of the patient. Just a minute. Successiva. Okay. This is the video. And I like to use a ligature to prepare. And I used to do the surgery in the same way that I do in open surgery. Look to the dimension of this vessel. The vessel was very big, so we decided to close the vessel with a stapler. We used a robotic 12 millimeter stapler. Then we did the selective ligation of other arterial and venous vessels using Hemolock. I have to say that I find Hemolock very, very useful. This was a very nice dissector that I asked to my colleague, adult surgeon. But as you have seen before, I started with stapler, but I have to say that I prefer to use Hemolock for vessel sealing, because they are the most safer instruments in my opinion. Then I had a little leak from a bronchus, and I put a suture. I have to say that I used to put a suture also in this in pulmonary surgery. Successiva. So this was the patient had drainage. The patient went to intensive care unit after surgery, due also to the time that the procedure required. It was not a short procedure. We spent about 4 hours. And I was also a little worried about the possibility to have some hemodynamic change in this patient due to the size of the arterial vessels, and also due to the age of the patient who remained with this malformation for a longer time. So this was the CT scan 6 months later, and if you can see, there was there was a very good results. Looking to the histological examination, this was very, very interesting, because we used to look to the histological examination of young children, and not, I have never treated a pulmonary sequestration in an adolescent. And we saw that there was segmental centrolobular artery of above average diameter. There was a fibrointimal hyperplasia of the vessels. There was a frequent plexiform hypertensive lesion. There was a muscular fibrointimal hyperplasia of the small arteries, and also of the small arterial vessels, with evidence of intimal occlusion and subocclusion. And there was also a subpleural and interlobular dysplasia of the venous vessels. So my conclusion, this is some reference regarding the uniportal video assisted thoracoscopy. This was proposed by Diego Gonzalez. And there are also some review published by our colleague in Florence. But in this review, if you look at the review, 17 procedures were made in pediatric age, and only 4 major procedures. That means that our procedure is an additional major procedure that is not yet published. My consideration regarding the surgery of intralobar pulmonary sequestration is that the presence of clinical symptoms and the vascular modification found in the resected lobe underscore the importance of surgical removal of this lesion. You know, there is some discussion about how to treat this lesion. I think that surgical treatment is mandatory in this patient if we consider the risk that this patient had, and also if we consider the histological pattern and the clinical symptoms. Regarding the UVATS technique, I think it can be proposed in older children and particularly in adolescents. And in this patient, it could be an alternative to VATS. But I agree with Mario that if I have a pneumothorax of a cystic disease, I prefer to do a VATS rather than a new VATS. I feel more comfortable because when you are obliged to do resection in several parts of the lung, with UVATS, you are limited in the movement, more limited than in VATS. This was my experience. It was very good for a lobectomy, but I think it's not always either for several segmental resection. I don't know if there is some comment regarding this presentation?
Thank you, Giovanna. I am agree with you about the UVATS technique. Also, I used this technique last week for right congenital diaphragmatic hernia, where it's impossible to do the suture of the diaphragm. So I, under control, thoracoscopic control, I perform the suture by little thoracotomy. So I think also in the newborn we can use the UVATS when the sutures are very difficult to do. No, I don't know if you agree with me.
My opinion is that is ideal not for small children. It's ideal for big children, older children, and for adolescents. Because otherwise I feel more comfortable with pluritrocal VATS, I have to say. But I used to suture also with conventional VATS. But in this case, lobectomy in adolescent, the general thoracic surgeon used to perform the surgery by UVATS, and I think UVATS is easier. Anyway, you have to do an axillary incision, and so you start immediately with the axillary incision. I don't know if Valerio is with us. Valerio Gentilino, are you attending?
Yes, Professoressa, I'm with you.
Okay, please say, give your comment, your opinion. You are an expert in this technique.
Oh, I would call myself expert anyway. As far, I just use the uniporta technique only for adolescent, as you did, and I haven't used it for lobectomies. I'm very interested in this new topic, and I met once Diego Gonzalez Rivas, and I'm trying to implement my expertise. I think it's going to be, as you said, much quicker, the learning curve compared to the classic VATS, but still a completely different approach compared to the open technique. So yes, I'm very interested, but so far I haven't been using it with neonates or infants.
I don't know if someone else in the audience, between the participants, has an experience in this field. Olga, are you listening us?
Of course I am. I'm very much enjoying your presentation, Joanna. Beautiful presentation. No, in fact, I haven't tried it yet. For a couple of reasons. I think, as you said, it gives you some limitations to the ergonomics, to the movements, and maybe I'm getting old, but I think it is basically a step backwards in some of the procedures where we have already mastered an all-in laparoscopic, thoracoscopic pulmonary section. I must say, though, later on I will present a case of congenital lobar emphysema, huge emphysema, no fissure, and I wish, Giovanna, I would have called you before, because in this case, where everything is so complex, it would have been definitely beneficial. I had to open it up, and I think your technique would have enabled me to keep on going thoracoscopically. Thanks.
Thank you very much, Olga. I think Mario is ready. Vito, what do you think? I am looking to the operative room in Bologna. I think we have to shift there. Mario?
Mario? Mario?
Anyway, they are working. So I think we have to follow the surgery now, Vito.
Okay.
Giovanna, you listen me?
Yes, perfectly. We are waiting for you.
Okay. I put inside 1 focal of 5 millimeters for the lens, 5 millimeters for my left hand, and 8 millimeters we have a problem.
There is a small interference with the audio.
No, yes. Listen me.
Yes, now we can listen you.
And in my right hand is 8 millimeter because now I use a 5 millimeter instrument to expose the apical zone, and now I use a 8 millimeter stapler for this resection. It's okay, you see? Well, you
Yes.
have a good vision of the operative theater and the thoracoscopic view. Giovanna, you have a good vision of thoracoscopic view?
Yes.
Very good. The view is very good. How, Mario, how did you collect the 8 millimeter stapler? Because I haven't. I have a 5 and 12.
Yes, but this is a new stapler of the Medtronic, and it is 8, and it's very interesting for the pediatric age because have a very fine hand of part of the stapler.
I am very interested to see because
now I show you
I don't know.
the instrument and the hand part that is very good for the pediatric age.
Mario, sorry, it's from robotic use, no? 8 millimeter?
Is for?
Robotic use.
Yes, also is for robotic use.
Okay.
But I use the 8 millimeter trocar because after I use a special instrument for the pleurodesy that I do.
Oh, I see. I did see before.
Okay, you see the last part of the stapler is very fine. And I use, okay, you see?
Yes, so we are looking, the view is very good. I have a question, Mario. How long is the cartridge? Is 3 centimeters, 4.5. Now I have seen 4.5 centimeters. Okay.
Un'altra carica, per favore. Another.
Mario, I have a question for you.
Yes.
How do you feel the opening of this stapler? Is enough wide? I mean, is as wide as the other? Is more wide? Is less? Because it seems quite wide.
Yes, it's like the holder. Okay. Stop. Adesso vediamo. Ok.
Mario, it's vascular stitch?
Yes, it's white. I want to see one moment. Okay, yes, un'altra. Please prepare the endo bag. Vito, this is the vascular, and there is another that is for the smaller vessels. This is the white, and after I feel there is the blue.
Okay.
You see that is very good. It's very good for the pediatric problems. Okay. Please prepare the endo bag. I think it's possible to use the 5mm endo bag and prepare for pleurodesy, and ask to anesthesiologist is all ready to prepare the next patient. Okay. Yeah. It's not important because there is no problem of oncological problem, but it's better to remove the part. Okay, out. Trocar, the auto. I put inside again the 8mm trocar. Faccia dare una. Faccia dare una. Instrument that I show you is possible to have the external vision.
Yes, Prof.
External, please, for Legia.
Yes, you have.
You have, I don't see, you have my external. This is the instrument that is possible to have the movement like, you see it in my instrument?
Yes, so we are able to see very well.
I have the movement like the robot. And in these cases, is need for the pleurodesy. And I put inside with a little brushing, you see, and this is for don't have the loss of this. Calma, calma, calma. Calma, calma, calma. Okay. Scappati centrale. Ok. Mi dà un'altra penetrata, per favore? Mi mette una moschita? Okay. And now start with the brushing. I prefer this method of brushing, and don't I use, it's possible to use the hook, but I prefer this. And it's possible to move very well the instrument to have a good use of your brushing.
Mario, excuse me,
Yes?
it's a special device, this little brushing sponge.
Yes.
Could you give us some information, because it looks very good?
Yes. After Francesca give you all technical information of this, because Francesca know very well. I use only.
You are a lucky man.
Yes, really. I agree that I am lucky. This is very interesting instrument. It's important to have manuality, and it's important to work with this in simulator, because it's not easy, but it's very efficacy, the instrument.
I am agree with you, Mario. So
Please?
the industry suggested to perform a adequate preparation for the use of this instrument.
Okay, now I complete the brushing in the apical part and finish, because I think there is no problem. Okay. I pull out the instrument and the brushing. And now I have the question for you. In these cases, you leave a drainage or not? Because if I think there is no problem for the lung, and if there is a complete expansion of the lung, it's possible to live without the drainage. What is your opinion, Giovanna and Vito and the older audience?
So, my personal opinion is depending from the condition of the lung. If there was a isolated lesion and the patient is not asthmatic, I mean, it's not a nerve-wrapping pathology, it's possible not to put a drain. But if the patient has other small cystic lesion, not peripherically, and he has a very restrictive pattern,
Okay.
He may have some problem in the post-operative period. So
Giovanna, no drainage.
A
Okay.
drain.
Vito.
I am drainage man.
Drainage man, yes.
No, another question, Mario. You use waterproof for area after recession?
Yes.
The pneumatic proof?
No.
No. Okay.
You are drainage man. Olga, what do you think about this?
Beautiful procedure, nice instruments, Well done, of course. But to answer your question, if you do a careful pleurodesis like you did, so for the lung resection, I would not leave a drain. But for the pleurodesis or even partial pleurodectomy, you will have 100, 120, 50 mil of exudates within the next 24 hours. And I wouldn't leave that in. I would put a 24-hour drain after a careful pleurodesis like you did.
Okay, my opinion, the audience have another, you want to speak about this problem? I don't see if there is a hand higher. Giovanna? No.
Valeria, what do you think?
I still leave a drain, Prof. I heard that at Gaslini Institute are getting towards no drain technique. So again, I'm very interested, but I haven't found the courage to leave the patient without so far.
Okay.
I
There
think
is
that
three-
the point that Olga underlined has to be considered. Probably we will have not a leak, but maybe we have some liquid production that has to be considered.
Giovanna, is 3 for the drainage and 1 no drainage. Because I am democratic operator, I put inside the drainage.
Very well.
Okay. Because my friend Vito, that is a drainage man, is happy. Okay, Giovanna, you have finished your presentation.
Yes, I presented one case, so I will be. I hope to be able to present the second case. So
okay, and
I will try. So
if you want to see for the drainage, the put inside, I don't use usually the incision of the trocar because it's not easy to have a complete drainage, because it's important to have the scar incision in the inferior rib and go inside in the superior rib. Okay. Now I put inside the trocar. Yeah.
Alberto.
Devo mettere.
Ok.
Fenestrata? Fenestrata. Mi dà da pulire, per favore. Ok, collegate per favore. I put inside the drainage and I finish my procedure. Se vogliamo provare, forza colleghiamo subito. I finish the procedure. Giovanna, if you want, continue with your second case.
Giovanna?
Okay, I will do. I will try to do. So I try. I have seen also Michele Torre. Hi, Michele.
Hi, good morning to everybody.
Good morning. When did you plan? When have you planned to do your presentation, Michele?
As you like and as Mario likes, I'm ready.
If you are ready, I have already done one. Mario asked me. I don't know how long does it take your presentation.
10, 15 minutes, 15 minutes maximum.
Maximum. So I am ready too, but I think it could be nicer to change the speaker and to have your presentation now. So please, Michele, go on.
Sorry, I cannot show a live surgery. The patient was not ready yet. And so just to present the theory of congenital cystic pulmonary diseases. I don't want to bore you about the epidemiology, but the frequency of these anomalies is quite higher than thought in the past. We all know that macrocystic forms have a negative prognostic factor, both prenatally and postnatally. And prenatally, there is still the debate if it's indicated prenatal treatment. For example, steroid therapy, okay, maybe thoracentesis, shunts, open fetal resection or exit resection. These are very controversial issues. I won't speak about that, but it could be interesting also this topic. Postnatally, usually they are asymptomatic. The infections are very frequent in cystic diseases. There is a calculation of about 30% of all cases and 10% during the first 12 months. Moreover, the malignant transformation is another factor to indicate the surgery. We have drawn algorithm, sorry, it's in Italian because this is in the official document of our institute. And after the prenatal diagnosis, when the patient is born, if the patient is symptomatic, is going through X-ray and CT scan, and he will be operated in thoracotomy. But this is the very rare case. The usual case is asymptomatic, so he won't do anything but observation and X-ray just before discharge. And in the first month, we perform usually the X-ray is negative. So to confirm that the diagnosis was still there, the CPAM was still there, has not disappeared, we perform MRI in the first months of life and without contrast in spontaneous sleeping. After that, if MRI is diagnostic, or in other words, it shows something, so we can organize directly the procedure, the operating procedure, before 6 months of life, and in the same hospitalization to do CT scan. As we have a lot of patients who come from far, we have to think about saving hospitalization. So we will organize CT scan just 2-3 days before the procedure. If MRI is not diagnostic, we prefer to anticipate a little CT scan around 3 months of age. If the scan is positive, we will proceed in all cases with surgery before 6 months of age, if possible. Again, treatment is another matter of debate. There are centers where they suggest the conservative treatment. We usually suggest surgery, but we can debate about that. And also type of surgery. Usually we prefer lobectomy, but this is another matter of debate about the partial resection. And the approach, usually we prefer thoracoscopy, but there is still debate in 2022 about thoracotomy versus thoracoscopy. And if in the more historical papers, there were not a lot of difference between the two approaches, actually, more recently, it seems that thoracoscopy actually offers advantages in terms of complication, less complication, and a shorter length of stay in the hospital. But on the other aspect, it's longer than thoracotomy, but not for everyone, as we will see later. Moreover, thoracoscopy has advantages in the long-term musculoskeletal sequelae and also in the long-term lung function, as these two nice papers show. So the operation time, I spoke about that, and there is difference because yes, it's thought that thoracoscopy is longer according to some paper, but in other papers this is not been confirmed. And this is another paper showing that the thoracoscopic resection, okay, but for children less than 5 kilo, for poor visualization and difficult mobilization of the lung, there is high risk of conversion. But here again, there were a shorter stay and also shorter chest tube drainage in a thoracoscopic group. Let's speak about how to position the trocar. This is a picture from Arnaud Bonnard, and because we took a little his approach. The first is under the scapula, the tip of the scapula, and for the camera, and the other three trocars on just above the diaphragm, and the screen is on the head of the patient, and the surgeon is on the feet of the patient. This allows is the same approach for every lung, more or less, and so it's very reproducible, and it allows to use ligature and stapler with a little more of space. In my opinion, I'm not sure about that, but in my opinion, with respect to the classical Rothenberg approach, this is, for example, one of our patients with a drain and also with the paravertebral block catheter that we can use. We have started to use in the very last cases, so I don't have a lot of experience, but it's a good idea, I think. This is the classical Rothenberg procedure. The surgeon is on the front of the patient, the screen is on the back. And the first trocar is for the camera is on the 5th intercostal space, and the two hands, one above and the other below, the space below. And but this position can change according to the lobes, according to the individual anatomy. Another attractive possibility is the UVATS, that means uniportal VATS. You know, in adult patient, this is maybe the preferred approach for thoracoscopic, for mini-invasive lobectomies. But they perform an incision that is around 4 or 5 centimeters. That is a big incision for a small infant. So I've found only this paper. I don't know if there are other experience published. The authors incise just 1.5 centimeters, and with special instrument they are able to treat sequestration. I didn't find anything about CPAM, but this is maybe an alternative, and it would be very nice to discuss about that. I don't have experience of that. This is the fantastic book that Holger Thiel suggested to me to learn lung anatomy, the GOSO, and you have to remember that, for example, the left lower lobectomy, you approach the fissure before, and there are different pattern of vascular artery, for example, R4 and R5 to the lingula, coming from here and 6, so there are basal trunk and the 6 to be divided, but sometimes there are different anatomy. For example, here you can see a 4, a 5, and a 4 here, and you have to control well both trunk, the basal trunk, and the posterior segmental branch. Then the vein for left lower lobectomy, we also performed after the artery, the vein, and finally the bronchus. This is a short video about a left lower lobectomy performed by Yast recently. It was a patient almost 1 year of age, because it was referred a little later to us. And the particular thing is that she had also a cyst here that we couldn't understand very well what it was. So the approach was like the Bonar position of the trocar, and we started with dividing the inferior ligament, and there was also a vessel coming from below, and you can see the cyst also. The vessel was a hybrid lesion, like a CPAM and sequestration. So we controlled the vessel because it was quite small with ligature, and we cut, as Rottenberg suggests. We performed 2 before divided to sigillation, and this is the vein. And we wanted to have the control of the vein at the beginning of the procedure. Sorry, I come a little because I want, okay, this is the vein, okay. We don't cut the vein at this time, but we wanted to be sure that we have the vein under our hands. And I wanted to show you the cyst that was that resulted at the end. This is the cyst that resulted at the end duplication of the esophagus. And here the fissure was not complete, so we had to gain the vascularity inside the fissure by dividing the fissure with the ligature progressively. You can see here the vein, the artery, sorry, but above the arterial plane, you can cut the fissure without a lot of trouble. This is the artery, and we isolated the artery, again the fissure above the artery. Here we controlled before with the lace suture, but later on we also used the ligature. This was the basal trunk, because you can see here the trifurcation of the basal pyramids. So we control in multiple ways, also with ligature, and we cut here, okay. Maybe it's very redundant, but we wanted to be sure. And then this is the A6 that was controlled later in the same way with the ligature. In this case, we caught a little of fissure, and here there is a vein. Okay, we had already the tape. And the final is the bronchus. Again, isolation. And then the stapler, that in this case was 10mm staple, not 5mm. And we complete the lobectomy. You can see the cyst also included in the resection. Okay, I finished. Thank you very much for your attention.
Thank you, Michele. I think we may discuss, I agree with you with the indication. I would like, regarding Univax, I have presented before one case about in adolescent, so I think it was indicated main there. I would like to ask the opinion of Olga. I have seen that Olga. Olga, are you there?
Yep, always yours.
Please.
Brilliant talk, brilliant surgical skills, Michele, and thanks for quoting me that I quoted the Goussot Atlas. I think everybody who uses it is happy to have it, even before any kind of operation, to prepare for it well, and to make sure that we all understand thoracic anatomy as good as we can. As you mentioned, I think this is clue when we come to all kinds of resections. And like you said in your talk, the left lower lobe is probably the most easiest one. But once it comes to more demanding procedures like the middle lobe or the left upper lobe, I'll talk about that later. We have to prepare well, because this may be so dangerous, and there is little time and little space for any failure. So congratulations to everything I saw. In detail, Michele, again, I would like to applaud the way you handle the vessels, the way you deal with the bronchus, just superb. One question to you, though. You know, I keep wondering which stapler to use. White magazine, blue magazine. Let's say you have a 4-year-old, you can staple the bronchus. Later on, you have a 16-year-old. Honestly, do you have a clue what to use? Vascular or parenchymal? What's the best in your opinion?
Sorry, I don't know. Thank you very much for your comments, and thank you again for this time in Egypt that we met, and you gave me some suggestions. I don't have so much experience.
No, direi di no. Grazie.
To answer your question, in 5mm stapler,
Certo.
I'm still trying, so I cannot give you an idea. I had a good sensation, but I'm still a little cautious about that. Usually we use vascular charge, but again, I think you should ask someone else, maybe more expert than I, about that.
You're so nice and humble. Thanks. Perfect comment.
I think if I can say something on this matter, me too, I am very interested in stapler, but I have to say that if it is a small newborn or a small child, I mean, till 6 months of age, and it is a peripheral bronchus, you can treat with 5mm. Otherwise, you can be in trouble, because there are just 2 lines of suture and they are not enough. So in the main bronchus, as a stapler, I prefer to use the big stapler, 12mm. I was very enthusiastic to see today the 8mm that Mario showed us. I think I will try, because 12mm is always too big in the thorax of a child. It can be used easily in an adolescent, but in a child is always very, very big. So, but if I have to select a cartridge, I prefer to, I consider the the dimension of the bronchus. If it is not very small, I prefer to use the vascular type that can have different color according to the company, because you know Medtronic is color and Ethicon other colors. But if it is really a main very thick bronchus, so maybe a more tissue stapler. In Medtronic is violet color. It's violet color, and the vascular is yellow. So this is my But I have to say that the Hemlock also for bronchus, and they close very well. They close very well. So I think we may consider also this device, not only for vessel, also for bronchus, because the bronchus, the problem with Hemlock is that sometimes they took they took space. And if you have to go on with the dissection, you are a little annoyed. But the bronchus is the last step. So you have more space, and you can use a big Hemlock and two Hemlocks for each side. Mario, please.
Yes, he's already Gentilino from Varese.
Oh, very well.
Show the preparation of the operative table.
Okay.
And
please, Valerio. There was Sebastiano who has the question.
Yes. Hello. Good morning, everybody. I have a question for Michele about timing. Why do you choose 6 months before? You said that you operate before 6 months. Why this choice?
Yes, because I agree with Rothenberg concept that even in patients without any clinical symptoms, after a few months of life, there is always more inflammation in the fissure. So I think that apart from the dimension that are more little, so it could be theoretically more difficult. Actually, I think to do a lobectomy at 4 to 6 months of life is better than to do that at 1.5 year of age.
No, I'm not talking about 4 or 5 years. I mean, as Giovanna said, you need enough space to put your stapler. And you know, to put a big stapler through a 12 millimeters trocar is an issue in a very small in an infant. Whereas if you just wait a few months more, you have more space and you have more instruments available to isolate your bronchus and you stapler it more safely.
Yes, you're right, but you find more inflammation.
Can I
comment? Can I comment?
Okay, please, Olga. Then I would like to do a comment too.
Sure. Ladies first. Giovanna.
Please, you first. You have
Sebastiano, I technically agree with you, of course, that you have more space in the older children. And in Europe, we tend to operate these children at the age of around 9 months to 12 months. But Michele is right. There is silent infection in these, at least colonization with some really weird bacteria. We did a pilot study together with Alan Flake in Pittsburgh and Philadelphia, looking at his specimens of CPAMs resected at the age of around 3 months. And you wonder, with modern technology like 16S microbiology, you see more weird bacteria, viruses than you think. So technically, you're right. Biologically, I think Michele has a point. Thanks.
I agree with you. You published a nice paper on this subject. I have to say you both are right. The problem is that you have to change the technique. So if you, Michele showed us an older patient, but if you operate a child under 6 months of age, you can't use the 12 millimeter stapler. It's impossible. This can be used after 10, 12 kilos and with some difficulties too. You have to choose another technique with the 3 millimeter sealers, with the 5 millimeter stapler, with stitch, with the clips. So you have to change the technique. But it's true that you will find infection very early. I will show you later in one of my cases infection at the early stage. So it happens. They are right on the biological point of view. So I think we have to move to Varese. Valerio, are you there?
Yes, I am. Can you hear me?
Valerio, there is something in your phone. So maybe there are two phones open.
Can you hear me now?
Yes, now it's perfect.
Okay, we are running a bit late with the preparation of the patient. So in the meantime, if you want, I can ask our scrub nurse, Roberta, to show us the open enteroscopic shape.
Valerio, we don't see
Go.
the camera.
Give us a second.
We don't have the camera of Varese.
Yes, we have some flu, but not really a view.
Okay, now we have perfect. But don't listen. Giovanna, you listen? Valerio?
No, Valerio, could you hear us? We are not able to listen you.
Valerio is not good.
Sound.
The sound, and the problem is that we have probably
We don't listen.
echo. Okay. We don't listen now. Nothing.
Good morning to everybody. I'm Stefano. You listen me?
We can listen you, but not very well. Could you ameliorate the audio, please? Is it possible?
Giovanna, if you want present your,
Yes, yes,
because I have a problem with
yes,
the
there
with
is
the
that
audio.
problem. We will wait for, okay, just a minute.
Read.
I will try to present my video. So
Regia, please.
just
Professoressa Giovanni Pettitoni, to remove, please, Varese, Regia. Okay.
okay. I will try to show my presentation. Share screen is here. This time it's possible to share. Share.
Yes,
So,
we see very well.
you can see very well.
Yes.
Okay, this is I don't know if you can hear the voice. The voice is not mine, but it's very good. This is the two papers that we prepared with Sara Costanzo, who worked with me for a long time. And if his voice...
After prenatal
yes.
diagnosis of a suspect CPAM,
could you
the
hear
little boy was
a
born
voice?
term and had no...
Mario?
After prenatal diagnosis of a suspect
Yes, Giovanna, yes. Say me. Yes.
term and had no respiratory distress.
We listen very well.
5 were uneventful.
Perfect.
Except for bronchiolitis at 1 month. A CT scan showed a cystic malformation of the upper segments of the inferior left lobe. A thoracoscopic excision of the lesion was planned. Surprisingly, the surgical field presented with firm adhesions between the thoracic wall and the site of the malformation. These adhesions were carefully treated, avoiding any major bleeding. A 3 mm radiofrequency sealing device was used to free the lung tissue and to expose the interlobar fissure in order to identify the interlobar vessels. The fissure was very closed, so that it was very difficult to identify the anatomical cleavage, and the dissection proceeded slowly. The same instrument was used to dissect the interlobar vessels and to divide them. No major bleedings occurred. Once the vessel is sealed, a partial section of its lumen allows to check if any bleeding occurs in order to decide to complete a definitive section. Bronchial structures were successfully divided using a 5 mm stapler. The 3 mm sealing device was also used to start the excision of the peripheral part of the lesion, although the wedge resection was completed with a 5 mm stapler. At the end, the specimen was completely excised through the 5mm stapler.
Mi sentite? Sì. Vedete il paziente?
Yes, yes.
So the patient was treated at 8 months and a half, and coming to the discussion that we did before between Michele and Sebastiano, there was a lot of adhesion and infection in a patient who appeared asymptomatic. So this is one reason, because I agree with Michele and with Rothenberg, Bonin, Olga, to try to treat this patient at least at 6 months and not later. And the following history of this patient, the patient was discharged with a perfect chest X-rays, but at day 16 after surgery, he came with a pneumothorax. I put a chest drain. He went apparently better, but then the day after he had again a big pneumothorax. So there was 2 options in this patient. One option, I would like to say the most acceptable option, to do a lobectomy, to convert the wedge resection to a lobectomy. The second option was to try to do a thoracoscopic exploration and to decide inside. So I did the thoracoscopic exploration, and I decided I would like to say the lung seems quite good. It doesn't seem a dysplastic lung. So I thought that the air leak was mainly due to a leakage from the stapler or a leakage from the dissection made by ligature. So I decided to do a suture, a stitch, and I did a suture of the lung, and the child was discharged in an healthy way. Look at this. This was my suture of the parenchyma. I did a continuous suture. And this was the X-ray before discharge. This was the X-rays at 6 months follow-up. And I have seen this patient recently. It means 3 years after this procedure, and is doing very well. So I presented this debatable case that I discussed also in IPEG in scenario cases 3 years ago, just to put in discussion the problem of wedge or resection or lobectomy in CPAM. Previously, Michele had, stated that lobectomy is a safe and is the most acceptable decision. And I would like to involve him in this discussion. But I think that in many instances, wedge resection can be acceptable. We have no longer follow-up. We have just a paper which made a comparison between 2 experience in Necker and in Robert Debré. So that means in thoracoscopic surgery, and it seemed that the results of lobectomy was better in terms of complication. But we have not long-term or medium-term follow-up of this patient. So I think it could be very nice to have an Italian register
Mario and has a big experience in wedge resection. I have some cases too, but Michele, who is following the section of thoracic surgery for our society, could be involved in this study. So I think it could be nice to have a prospective study. I have finished this case, then later we present the lastest one. Mario, could you hear me?
Yes,
Vito?
very well.
Vito?
Yes, yes.
What do you think?
Vito, please. Vito, okay. Is the review of the pneumothorax with minimally invasive surgery is courageous, but it's important to have very big experience like you have, Giovanna, because you are lucky to found immediately the leakage of and the problem. Sometimes is not easy because it's possible to have the bleeding and it is impossible to see very well what is the leakage. But I think is the best solution that is possible to do in the cases that you show. This is my opinion.
You are an expert thoracic surgeon. I agree with you. It's not so easy to find the site of the leakage, not only in mini-invasive, also in open surgery sometimes. And obviously, to perform a lobectomy is the most safer solution in this case. But I tried to do, I was lucky to find the leakage. I tried to do the suture. The suture was effective, and this patient still is lower lobe, because we have to know that small children has the possibility to reconstruct their lung, not only to expand, but also to reconstruct their lung. And this is one argument in favor also of early surgery. I don't know if Michele is still there, and also Olga. What do you think? Olga?
Probably is not connected.
Maybe.
I won't say that if you don't have a big experience for the first time that you won't do a redo, misredo for the young surgeon, please to prepare to quickly converted. It's possible to see with the minimal invasive surgery, but don't forget to have and is ready for a quickly convert of your procedure in the open procedure. This is for the young surgeon, because we have many young surgeons that attend to this course, and I think is very important.
And do you think that Barese is ready?
It's possible to prove if is ready and have a solution of the audio.
I have another case, the last one. But if they are ready, I think it could be nice to look to their procedure.
Also in Bologna, we have the other cases for the moment that we prepare the operative theater, because in the Bologna theater arrived the next patients, and that is a big intralobar sequestration that probably I show you the open technique. I start with thoracoscopy, but I won't show you probably the open technique, because it's the bigger vessels and there's a big sequestration. And Valerio, you are ready with the audio, or you have a problem? I ask also Bologna Regia if have the image from Varese. Pesci, you have the image from Varese? Is a flu. Okay. We have the image from Varese, but we don't have the audio. Mirella Moggiatti, is possible that you describe what do Valerio in this moment, because we have a very good image from the operating theater, but please only one phone, because it's impossible.
Can you hear me?
Now,
Can you hear me, bro?
Yes, now I hear very well you and I see.
My apologies for these technical troubles.
No problem.
So
but I see that you are lucky because it's really an extra lobar
sequestration. It does look like an extra lobar sequestration, yes.
But don't have the vessels from the wall, but I see that have the vessels from.
I can see like something that could be a vessel there.
Okay, now I see.
But I just need to clean a bit more the structures, and then I'll get back to you if you are happy, bro.
Really, the diagnosis that you think immediately is correct because it is extra lobar. Yes?
I think so, Prof. Just give me a couple of minutes to clean up these structures, and then I'll get back to you if you agree.
Okay. We have a very good vision.
Wonderful.
Okay.
This is good. This is good. And extra lobar is back.
Inferior lobe of the lung.
Yes.
I can see vessels now.
Yes, I see very well the vessels. And
so what I would do now is to clean up the vessels and try to figure out the anatomy properly, and then probably occlude them with Emoloc and remove the sequestration, if you all agree.
Probably, yes, probably it's possible to have advantage if you put inside another trocar to put down the lung, and in this it's possible to see very well, and you have a very good control of your vessels.
So beautiful.
Yes, so beautiful, but I agree with Mario. It could be safer to have another instrument, maybe a Maryland, so you can use the Joanne to maintain the lung, and you may work with another hand to dissect properly the vessels.
That's a good suggestion.
Yes,
but how about positioning? Can you rotate the patient better?
I could. Could you please rotate the table towards me, Giuseppe? Can you puoi girare il tavolo verso di me, il lato destro? More. Okay, thank you.
Sorry, didn't have much.
I'm still trying to figure out the anatomy, of course, before carry on with instruments.
Okay. See the bene.
There's a big vessels probably somewhere here. what I would do, I would start to clean up the pleura at this level.
But Valerio, the vessel is more larger than sequestration.
Sorry, I didn't get you properly. What did you say? Can you repeat, please?
No, I see that the vessel is more larger than sequestration. It's very bigger.
Yes, you're right. That's why I'm scared, and that's why I'm touching this structure without doing anything.
I didn't want a question to audience. If you don't, we use another trocar. It's more easy to do a stapler.
Yes, I haven't got a 10 or 12 millimeter trocar inserted. It's a 20-month-old baby. So, well, I will try to clean up anyway the vessel, and I'll see. But of course, it's a good suggestion, yours. Can you open the 3 millimeter vessel sealer, please?
Where's the origin of that thing?
I'm trying to find out, Olga.
Yeah, that's probably the aortic release somewhere there.
I think so.
So beautiful. Wish I would be with you.
I wish too, Olga. you would be with me. I'm a very slow surgeon, so if you want to do something else in the meantime, I can call you back when the structure will be cleaner than this. It's up to you.
Valerio, could you hear me?
Yes, I can.
I know, because I think you are using a 3 millimeter sealer as I used to do. We are very close to Steve. I like this instrument. I have to say.
I think it's a relatively good instrument.
It gives the difference. I think Bologna is not ready, so we would like to follow your surgery anyway. Did you perform in this patient a CT scan before?
Yes, I did. This patient is, as I said, a 20-month-old baby boy coming from another country. So I had the chance to see the CT scan just via mail some months ago, and it was quite an old CT scan. So I decided to repeat one yesterday. I must admit, I couldn't see the systemic aortopulmonary vessel on CT scan. That's why I was a bit concerned.
From when is coming the vessels, but
exactly. Yes.
It seems tragic looking to the picture. I am not sure, but it seems this way.
So I wasn't 100% sure if I had to do a sequestrectomy, as I'm doing or trying to do, or a proper lobectomy in case of a CPAM. Well, much better than this, I think.
Sorry to jump in, but isn't there on the left side of the picture still another lobe of that thing or something?
This one.
Yeah. So if that isn't the what if that isn't the base? It looks like the base, but
busy trying to find out the anatomy. Yes. I hope to find it out.
Sure.
His name.
Take your time.
So you don't even want to get a coffee or anything in the meantime.
Sta staccando. Che stanno facendo?
Stanno guardando le fotografie che sono andate a me.
Domani a che ora vanno? Domani a che ora? Qua un bene romano.
Era a vedere la Trabacchi.
Valerio, you listen me? Valerio?
Can you hear me, Prof?
Yes, now. Yes, I listen now. You put inside the other tracker or not?
Not yet, Prof. I was concentrating on this structure, but probably I would do, yes. I think one is the vein and one is the...
Yes, is the vein, the artery, yes. But if you put inside the tracker, it's possible to see very well. And if you have problem, it's possible, because I don't know exactly what you have back of these
Sure.
vessels.
I could put a 3 millimeter tracker probably.
I don't see well what you have back of these two vessels, because if you have another little vessels,
I have to say that I agree with Mario Safer.
I think I could put a 3 millimeter trocar.
Yes, with the.
Sure. I'll carry on just a second in the meantime. Trocar is coming. I think I'm gonna put a hemlock in this artery, if you agree.
Yes, I think is a good idea.
Yes, which size? Which size? You know, there are 3 different sizes. Which
I've got
color?
an M. I've got an M.
Medium.
Medium. With a 5 millimeter instrument.
And excuse me, Valerio, that I am
Yes,
disturbing you.
No.
So which kind of pot have you placed?
I've got a
5 millimeter for optic.
Yes.
3
yes,
millimeter for ligature, but do you have a 5 millimeter too?
No, actually, I put a 3 5 millimeter trocars on this baby, and I'm changing the cap between 5 and 3. Now I'm gonna remove the vessel sealer and change the little cap between 3 and 5. This is what exactly I'm doing now. It's a bit waste of time, but anyway. Okay, envelope.
Hi Valerio, it's Michele.
Hi Mickey.
You prefer Hemlock? Can you comment about doing in ligature or Hemlock?
Well, as you know, I'm sorry, Mickey, I'm just trying to insert there. I'm very cautious, so what I'm gonna do probably is place 2 hemlock and ligature above it if it doesn't interfere with the clip.
So you're perfect confident on Hemlock, and or when you use Hemlock, you use always ligature, or sometimes you are.
Well, sometimes I just cut with the scissors. Yes.
Okay.
Probably now I'm gonna clean a bit further the vessel and use a vessel sealer on top of it. I'll see just now. just grab this right closer. Probably I'm getting into the parenchyma. Now it's bleeding a bit.
I think you can use directly the ligature.
Yes, I think
there.
so.
Going close to the parenchyma is better than having bleeding of other small vessels. You can go. You have to hemolock. The only problem with hemolock is that they take little space, so you will have.
Sure.
And the other problem is that you don't know exactly if there is another small vessel. This was certainly the main vessels, so you have to consider that it's very important to have a good hemostasis.
I will go now with the vessel sealer. Scissors. I think it's time to put the extra trocar, Prof. Okay, this is a 3mm instrument.
Valerio, this is the artery.
I thought was the vein, but I'm not entirely sure, Prof.
Because the sequestration increase. Probably you have ligated the vein, but not the artery, and this is the artery, because if you see the sequestration is increased.
Yes, it can be, you're right.
You have quickly to close, and doesn't matter.
Yeah.
And after close days, if you are sure that there is no vessels, with end loop, you have finished your procedure. After ligation of this, with the hemoloop.
It's enough. Pay attention because they are fragile. So you are ready to clip.
I agree. I agree with Giovanna.
Mario, we are too old. we became too old, unfortunately. I have to say that Mario is still younger than me. Not a lot, a few months, I think. Doesn't matter, it happens.
Okay. Okay. Yeah.
Sì. Sì, deve fare la richiesta, è già prenotata giù. Lei deve farlo al braccio sinistro, sì. Esatto.
There's another vessel there. No. Chiudila, per piacere.
Valerio. Valerio, you listen me?
Yes.
With your sealer, cut the parenchyma in the left side.
I agree with Mario. You have now to go peripherically.
Don't down, but in upper. And if you work the parenchyma, because I think there is no big vessels, but it's only parenchyma, you have a good vision of the vascular tree, and you don't go to blind to cut here or in the right side. Please, to prepare this part. Okay, this.
I have another suggestion. You can change your hand. You can take the lung, the sequestration with the other hand and cutting with the left hand. In this way, it's more easier.
I know what think Valerio.
I think I'm happy, Prof.
No.
And lucky to have you.
You are disturbed, but two others.
I wish I could have you
What
every day.
we try to do with our collaborator too. Okay. Very well.
this is the limit of the 3 millimeter sealer that don't have the blade that have the ligature, because in these cases you sealer and after to cut.
Yes, if you have a 5 millimeter access, it could be quicker for you to have a 5 millimeter ligature. Pay attention here.
Yes, pay attention because
another vessels.
yes.
I have seen another vessel there. So maybe you were not wrong before. Exactly. Take down the lung in order to see very well what you have there.
Sorry for bothering, but I know that, now there are 100 surgeons in the room who would like to help you on that case. But I would like to come back to the point Giovanna just raised. Actually, I don't see clearly what kind of a lesion that is. Is that a simple extrapulmonary sequestration with its own vascular feeder from the aorta? Then you have to go down to the aorta, or is it a sequestration within one lobe? You're at the level of the lobe in the parenchymal tissue at the moment. Question, does it help to, just for a minute, to put the scope into a different trocar so that you get a different angulation down to the aorta and see what's going on?
You can try. Thank you for the suggestion.
No. Sorry. This is exactly what I didn't want. You have your flow and people interrupt you. And when you get 100 smart comments, you change your operation 100 times. I sincerely apologize. I didn't want that.
No. I think it's a very sensible. I think it's a very sensible suggestion.
Sorry, I respect your flow, and I didn't want that to happen. I'm very sorry.
No. Give me an instrument, please. Just the best system. Thanks.
Anyway, now the sequestration is black. So this is a very good point.
But I think Olga's suggestion is very sensible, as I said. I mean, we couldn't see any feeding vessels from the aorta on the CT scan. So I'm a bit concerned that is something that we can call extralobar sequestration, of course, but it's not a proper extralobar we all know, with a big feeding vessels getting out the aorta. So I think the only thing I can do, if you agree, is to carry on slowly and trying to find out all the vessels that can merge from any structure of the lung, rather than the aorta, probably.
I prepare envelope and I put inside the envelope. This is my opinion. Because
It does look like another vein or something there. From the inferior pulmonary vein, probably.
Okay, but if you put here and the loop, you have finished your procedure because you have the pulmonary vein is down, is here.
So you wouldn't clean a bit more here, Prof, just to.
Yes, what you want, what you think. But if you put in
The only problem with Endoloop is that he has placed some hemlock. So they take space, and sometimes it's difficult to place an Endoloop without displacing the clips. What do you think about my suggestion?
oh, yes.
I think, Valerio, you could put the hemoloop just below the hemolock. There is a little space to pass it.
We have the space, and after you cut the parenchyma upper the hemoloop and put the endoloop down of your hemoloop, and you are sure. And after cut with the sealer the parenchyma, but before you see very well.
The problem is that the lung is expanding. For this reason, he can't see now. He has to wait a little bit that the lung is again collapsed. But anyway, Valerio, you can also dissect and close the vessel as you did for the other, if you feel more comfortable.
I'm just trying to reposition myself. Okay. Sorry.
Valerio, on the TC, venous drainage where? Circular, systemic or pulmonary vein on the TC?
I think it was a pulmonary vein.
Pulmonary vein, okay.
Yeah.
Valerio, you put down, see, you put down to the hemoloop your handle loop, leave the hemoloop and cut upper the hemoloop, the parenchyma, because you have the space.
I agree with Mario, because there is a little space between the vein and suppose the pulmonary inferior vein.
Can I disagree? just a for the younger ones in the audience, just a matter of caution. In IPEC and all of these courses, we teach before you ligate, get enough length, get enough length, get enough length. And personally, I know that it's a little bit frustrating, but personally, honestly, I would not just swing a ligature around it and cut above. I don't know what this is a mass ligation and I don't know how to control it. I'm sorry, first time ever in years, Mario, that I disagree, but this doesn't seem clear to me. And for safety reasons, I would identify the vessels, I would identify the structures, and then triplicate, ligate that with 2 clips central and 1 clips peripheral. Or you just take the endogea, but this is then a mass ligation without control of what you're actually doing. You probably will get by. Sorry for being so German.
No, deve essere sì.
Valerio, you listen me?
Yes, Prof.
Okay. Now you clean, perfect, your operative field, and you see there is bleeding. There is no bleeding. It's very good. Where is the hemologue?
Okay, just a second, Prof.
Yes, it's good. Perfect. And you remove the sequestration to use endo bag or remove from?
I think I will go through. I will go through the lowermost trocar access.
Okay. Because
I've got a question. I've got a question for you now, Prof. If you don't
Yes.
mind, would you leave a drain?
Yes, always I leave the drainage. I am like Vito Briganti. I am
Drainage man.
Yes.
Me too, Valerio, because the risk is the bleeding. So if you have a drain, you can detect immediately. I am sure that you will have no trouble at all.
Sure.
Okay.
So I apologize for having been so slow, but it's
very well done, Valerio.
Valerio, slow is safety. You don't apologize because slow is
Thank you very much. Thank you
and
very
in
much.
this case, okay, thank you very much. Giovanna, you have the last case of
Yes, I have still a case.
Mi avverti tu quando devo lavorare?
Regia, please change. Okay. Giovanna, if you want to start.
Okay. I don't know if you can, I try to share, just a minute. I try to share the screen. Okay. Share. This is another video with the voice. So.
Our patient
Could
had
you
been
hear
operated
the voice?
at 1 month.
Yes, we see and listen well.
Pulmonary blastoma of the right lung through a thoracotomy. At follow-up, at the age of 7, a CT showed 2 large cystic formations of the right upper lobe and 6 additional cysts of the middle and lower lobes. After 3D reconstruction from CT images and a multidisciplinary discussion, we planned a thoracoscopic resection of the upper lobe and the residual cysts. Through a 3-trocar approach, multiple adhesions at the level of the pleural cavity were lysed. In the presence of huge cysts, it is possible to empty them to obtain better visibility within the pleural space. After identifying the upper, middle, and lower lobe, the dissection was begun through the main fissure. Multiple adhesions at the level of the fissure were carefully divided, using blunt dissection and a sealing device to avoid bleeding. Since the patient had previously been operated and some adhesions appeared harder, it was necessary to proceed with sharp dissection through the use of the scissors and also of a 5mm stapler. Once the vascular structures of the fissure were identified, These were isolated and treated with a 3 mm radiofrequency instrument. A safe way for the treatment of the vessels is to seal them in 2 or more points and to cut them gradually in order to ensure that there are no accidental bleedings due to incomplete ligation.
Sto meglio. Ho messo il telefono.
The superior lobar bronchus was exposed near its bifurcation and divided. After compressing it to reduce its diameter with the 5 mm stapler, completing the upper right lobectomy. The lower and middle lobes were then explored to identify the remaining cysts that were removed with wedge resection using a 12 mm stapler. Luckily, the histological examination allowed to demonstrate a cystic dilation of the alveolar spaces associated with chronic inflammation without blastoma recurrence.
Allora, ok. Mi sentite? Mario, mi sentite?
Giovanna, ti sento, io ti sento.
Okay, perfect. So I presented these cases that Olga know very well because we discussed it also in our meeting in Kutai years ago, because this case was treated not by me. I was performing the surgery with Stephen Rothenberg due to the complexity of the case. The other 2 cases was made by myself. So, but I would like to discuss this case because it's really a peculiar case. I treated this patient who went at 1 month of life with severe hypertension pneumothorax with open surgery, and the histology was blastoma without Dicer negative. The patient developed this cyst inside the lung, and the cyst remained stable during 7 years. So he did an initial 6 months chemotherapy, and then we discussed also with our oncologist in Milan, but also with foreign experts, if it could be really affected by blastoma or not. And the main opinion was maybe there are expansion cysts and not blastoma, due to the even long event-free survival. So also Stephen Rothenberg was of this opinion. So I decided to perform the reconstruction with the program Visible Patient by Luc Soler, and then I invited him and we did the 6 resection, wedge resection and lobectomy, but preserving the lung of the patient at the end because he has still a lung. So we organized also an intraoperative and histological examination. I have to say is not really very available, very valid for blastoma, but it can give anyway an opinion. And the opinion was no blastoma after the first resection. So we decided to go on, and at the end, Steve and also the other experts were right. So this patient was not affected by blastoma anymore, but he was a low-grade blastoma at the beginning, and he had resection and he had expansion cysts. So if you have seen, it is possible to treat peripherically the vessels in lobectomy also with the 3 millimeter, which can be effective, but you have to use strongly. That's true. Regarding the 5 millimeter stapler, I am not so convinced about the efficacy. It was efficient in this case, but I have not good experience in others. So I don't like to use the 5 millimeter. I prefer to use bigger stapler. Mario, any comments? Michele?
No, I don't have comments. Michele?
A very nice case. It was not possible to have the diagnosis before the procedure, just doing some kind of biopsy, thoracoscopic maybe, just to have the biopsy, because the approach would change completely in case of tumor or in case of negative finding. Even you could decide also to leave some cysts if it's not too bulky. What do you think? Microphone, Giovanna, sorry, we can't hear.
Giovanna, you are mute. Okay.
Yes, but it was blocked. So we discussed a lot this option. The only thing is that the family wouldn't perform several surgery. So we decided to organize a biopsy during the first procedure. And we thought that it could be safer to take away all the cysts, because you don't know if one cyst could be affected by tumor. If we had a positive answer, obviously we will move. We have planned to move to thoracotomy to do a pneumonectomy, because there was no other option. But if you look, any specimen was taken away by endobag, and at the end, and then maybe we were also lucky. But I have to say that I followed the advice of other experts worldwide.
Giovanna?
Yes?
You listen me? Yes.
Yes.
And I go now in the operative theater for the second cases, that is lobar sequestration. And I show the cases from the operative theater. And if you want, now you have finished your particular cases? Yes. And if it's possible, and if it's connected, Molinaro, Francesco Molinaro from Siena, because of a presentation of cystic pulmonary dysplasia for spontaneous pneumothorax.
Yes,
Molinaro? Okay.
yes, I'm
okay.
here.
Okay.
Good morning, Professor
Good
Lima.
morning.
Good morning, everybody.
If you are ready, Francesco,
yes,
this is the moment.
we are ready. We want to talk about spontaneous bilateral pneumothorax treated to our center, at our center. And the second surgical procedure was scheduled for today, but unfortunately,
Francesco, I'm sorry, we don't see anymore.
Because with video, but
no, your face is on the video.
Yes, but you know, there is our interns that will present the presentation. and Elisa Chiarella. Okay, now I want to see if I try to share my video. If you can see.
Okay.
Perfect.
Yes, yes. Well.
Okay. Okay, this is the presentation. Okay, a presentation with the
Francesco, okay, it's perfect.
Okay, Elisa Chiarella will talk about this case.
Mi sentite?
Sì, sentiamo.
Ti sentiamo perfettamente.
Sentiamo bene,
Okay. Good morning to everybody. I would like to talk about a clinical case of a spontaneous bilateral pneumothorax of a boy 17 years old with a family history with a mother insulin-dependent mellitus diabetes. Father died for colon cancer. Grandparents died for lung cancer and ovarian cancer. In the past, medical history is documented a Crohn's disease since 2017 in follow-up at another hospital. He came in a peripheral hospital for a very important chest pain at the right lung apex, reported to the back, associated with breathing difficulties for 4 days. In 25 August, a new onset of chest pain with the same characteristics on the other side suggests that the patient came at the emergency department of a peripheral hospital. The colleague subjected him a chest X-ray control with evidence of bilateral pneumothorax. So he was carried out to our emergency department, and in this there was placed chest drainage on the right side at the chest X-ray control. We show a very improvement in the ventilation with minimal flap in the right side. So we was hospitalized in our pediatric surgical department. The day after, we subjected him to a CT scan with evidence of minimal pneumothorax of the apex of the right apex, and very important pneumothorax on the left side in the apex, and also in anteromedial side and anterior side. This is a video of the intervention, thoracoscopic left lung apex resection and pleurodesis. This is the left apex, the blebs. So we made a resection with green graft of the Stapler. We used 3 green grafts for the resection. We made pleurodesis with the scarification of the ribs, 3 scarification on the ribs. And at the end, the placement of chest drainage. So, of the chest X-ray control, there's a good left lung ventilation with good expansion in the right, in the left apex, minimal flap in the right apex. So we decided to remove the right drainage, and after 5 days of the hospitalization, left drainage was removed instead 7 days after the operation. At the chest X-ray control 1 month later, there is a good improvement in the imaging and in the ventilation. So what's the next step for these patients? The pediatric surgical literature In the pediatric surgical literature, there aren't codified guideline for the management of a bilateral primary spontaneous pneumothorax. So this is a study for Italian group with a proposal of management algorithm in the case of ipsilateral recurrence or contralateral primary spontaneous recurrence. Another problem and another question we want to subject to you is a single time or two-stage treatment for bilateral spontaneous pneumothorax are more correct, and the problematic of recurrence. So, this is a study of the literature of adult with percent of recurrence more representative in the case of ipsilateral treatment with significant showing of the blebs in CT scan. So I finished. Thank you.
Okay. We want to discuss with you this our case because it's a bilateral, and then we choose this kind of treatment. Then schedule the other side after the first surgical procedure. What do you think about this? This kind of approach? What do you think this is our problems gives to the audience?
Vito, what do you think? Vito, are you there? No. So I think it is not an over-treatment. I think when you have bilateral lesion, it's very important to pay attention to the other side. I had several years ago an annoying experience. We treat one side immediately after surgery, the patient made a pneumothorax on the other side. So I think you have to treat obviously both. But I would like to ask to the other people who are present. Vito Briganti, are you on the screen? No.
Giovanna, I agree with you. It's Michele.
Michele, thank you, Michele, for your help. Thank you.
If there is a pneumothorax, already a clinical or blebs at the CT scan without pneumothorax, we prefer to go on the other side. Sometimes we have waited, we have done only one side and follow up, but usually they recur or they need finally the contralateral surgery. So I think it's a good idea already scheduled. I don't know if in the single time, but both sides, yes.
Okay, thank you, Michele, because in our case, the right side was treated by the position of a chest tube. Then the problem was to the other side, and then we decided to do that, and then to schedule the right side after the first surgical procedure. Now, some some adult surgery used to do simultaneously both sides, but we choose to schedule the other side with an elective procedure. This was our decision.
Yes, my suggestion is to pay attention when the patient became awake, especially if you have a severe restrictive pattern, if you have blebs on the other side, because it can happen what I observed in my old experience, that just a few hours after the first surgery, we can develop the pneumothorax on the other side. And I have to say that the patient that I mentioned who was an adolescent, and we treated him very well on one side. He went visiting later another surgeon, an adult thoracic surgeon, who said, why they didn't perform both sides at the same time? So,
yes.
Obviously, as pediatric surgeon, we try to be not very aggressive, but
Yes.
I think that in the consensus of the family, we have to say that there is a risk of a yearly appearing of a pneumothorax also on the other side, and so they are prepared. Our old patient was not prepared. They maybe also us were too optimistic that we will have a longer time to treat the other side.
Another question that I was to speak in case of pneumothorax, we have some concept with our radiologist colleagues, because they don't love to perform a CT scan when there is a pneumothorax, because they said that it's not so clear to see the blobs when there is a pneumothorax. Then in other cases, we have to... Yes, we have to fight. And for another case, we have to wait. We put a drain, we wait and schedule CT scan after some days, and then schedule the procedure. And there is, in our center, there is this kind of concept with the radiology. I don't know if you have the same problems with in your...
Michele, what do you think?
Sorry, I was answering the phone. What is the question?
Question is the CT scan. Our radiology, the radiologists don't like to perform CT scan when there is a pneumothorax, because they say that it is not so clear to see the blobs, and sometimes we have to fight, or sometimes we have to schedule after the resolution of only with the position of the chest. What do you think about it?
I think CT scan is more sensitive when air is absent, because air can compress the lung and hide some little blebs. So we tend to re-expand the lungs, and only at that point we perform CT scan.
Yes.
I agree with you. Any other suggestion from the floor? I don't know if Mario is already ready for the next case of right extralobar pulmonary sequestration. Mario, could you hear me? No. I would like to contact Valerio anyway. Valerio Gentilino, could you hear me? Maybe he's still busy to fix the drain of the child. All the things.
He's drinking something.
Valerio?
Yes, Prof.
Am I bothering you? I hope no. So
yes, you can, sure.
How is your child? I am sure he's well, he's doing well.
Yes, he's almost awake. I left the drain as suggested by all of you, and I'm gonna take him to the ward, and probably tomorrow I will remove the drain if the night will go smoothly.
Okay. So what is your attitude, and also the attitude of Michele regarding the anesthesiological, aspect, the post-operative anesthesiological different aspect? I mean, do you prefer to leave this patient awake, or do you prefer to attend some hour and then to see how the patient is doing, especially regarding pH, CO2, and then detubating, and then to proceed with detubation?
Well, if the patient is stable and healthy, I ask the anesthesiologist to wake him up in theater. Sometimes they keep him in theater post-op 1 hour or 2 just to stabilize him and wake him up. But if possible, I send him to the ward instead of the pediatric ICU. That's average patient, of course. I'm not talking about every single patient.
Really?
More or less the same. We wake up the patient and we extubate him on the table. And depending on the age of the patient, the feeling of the anesthesiologist, they will decide if to send him in the ward directly, or sometimes some hours or one night in the intensive care. But usually we always remove the tube at the end of the operation.
Okay.
Giovanna?
Sì? Yes,
no. To this purpose is the anesthesiologist, the team leader. If the anesthesiologist decide in ICU, the patient going in ICU, in also aspect in operation room. Only anesthesiologists decide the future of this patient. Always.
Yeah, that's always true, but we try to discuss together. So if I have to say that in Pavia they are very open, and so they used to ask, and we decide together according to the condition of the patient. Obviously, the anesthesiologist is a friend of the patient, and they try to protect the patient. And if they know if there is an ICU2, they prefer to stabilize the patient before detubation, and maybe they prefer to control the patient in intensive care unit also for one night, not longer. I have also another question to Valerio and Michele, and also Vito. Did you apply routinely a NIRS monitoring in this patient?
Yes, we do. We apply for every single patient the NIRS measurements.
Yes, I think so. We also do that.
Yes, always.
I think it's very important in thoracic surgery more than in other procedures. So regarding the advice coming from the section on thoracic surgery, I think it's very important to underline this aspect in our guidelines or recommendation anyway. So I have no other question. Maybe the operative theater in Bologna is ready. Mario, are you ready?
Giovanna, you listen to me? Yes,
I can hear you.
Yes, I speak from the operative theater. But we have the artery, the anesthesiologist, and we are ready. If you want, we have prepared because there is a message from Olga that I don't see because I don't have the lens. You see the message of Olga, please?
No, Mario, I'm just asking when
Okay,
when my presentation would be best to hold, because I just got in a 15-year-old boy with ulcerative colitis, 10-centimeter abscess, and a dilated right ureter.
You are ready for your presentation?
Always, always.
Okay.
If you are ready, you can do immediately.
Giovanna, you agree?
Yes, I agree completely. We
Okay.
are ready to hear all
When-
the presentation.
When are you ready, I call you, okay?
I'm
Okay.
always ready. Whenever you want. No stress.
Please, audience, go on.
Okay. Thanks, everybody. That I can jump in. I'd like to share my screen. Hopefully you see everything. Do you see my screen? Giovanna?
Yes, I am able to see very well.
Okay. Yeah, it's just a brief talk about congenital lobar emphysema, and maybe I can point out a few specialties of this entity. As you all well know, congenital lobar emphysema is one of the rarest congenital pulmonary malformations. If you look at this paper, then it is about 5 to 10% of the lesions that you see. Per definition, it is a very rare anomaly that is, of course, a developmental malformation with a wide range of presentations and associated with a high morbidity and mortality. Especially in newborns, it is characterized by respiratory distress syndrome due to an overexpansion of one node or more pulmonary lobes. So it can be a bilobar disease indeed. The affected lobe is essentially non-functional. This is important when we later take a look at preoperative imaging, like presentation of the vascular supply. And it's most frequently recognized in newborns. However, some patients come late. What's the clinical presentation? Let's refine this statement about a little bit, taking this publication from Sean St. Peter and others of the Midwest Pediatric Surgical Consortium. So these guys, you know, from IPEC and other international meetings that know very well what they're doing. In this multi-center study, they have 53 children with CLE among 506 lung formations. So that proves the point that the incidence is about 5 to 10%. And in only 24% of these patients, there was a prenatal detection possible. This is a little bit different to the CPAMs that we'll discuss later today. 32 of these CLE patients presented at birth. So it is a neonatal disease, which requires adequate management from you. And please note that at this point already that the left upper lobe, so the most difficult lobe to operate, is the most frequent. And I think this makes CLE very special to us. Postnatal management. It does not differ from all the other pulmonary lesions. You do the clinical study to assess whether you have emergency case, yes or no. You look out and watch for associated anomalies, mostly cardiac defects in some patients. You do the regular workup with ultrasound, CT, angiography, and MRI, and then you confirm the diagnosis. And out of all of these, you recommend the adequate management to the parents. And of course, you have to adjust it to the clinical state throughout the following course. Let's refine diagnostics a bit. A study that looked at over 27 years of experience with dealing with CLE patients, few patients only in all of these years, but a good study to just assess what has to be done in terms of diagnostics. Yes, chest X-ray is basic. CT scan is very powerful in not only detecting the size, the exact lesions, the segments, if you believe in segmental disease, and the lobe, of course, but also if you do CT angiography, you find the adequate vascular supply. I will come back to that again later. And as proved in the previous paper, the left upper lobe is the most affected. But be aware, it may look like a CLE, it may sound like a CLE, it may smell like a CLE, but it may be something different because there are rare reports that some other diagnoses mimic the CLE. For example, left main bronchial stenosis, and I think we have some wonderful people in the audience and among the masters operating today to comment on that. The pleural pulmonary blastoma has been mentioned before, something we are all very afraid of. That was incidentally found in the CLE. And then great vascular anomalies, which of course you always have to be aware of, and which we were during this morning in these careful operations. Finally, emergencies happen. Again, very, very rare that they decompensate. But if you look at the highlights of this slide, it says the diagnosis of CLE requires contrast and has computed tomography for imaging, low ventilation pressures, and a specialized team to deal with this. And this is very often happening. This huge cyst is misdiagnosed as pneumothorax. And especially in secondary or primary hospitals, pediatricians or surgeons tend to insert a chest tube, leading to tension emphysema. And of course, contamination of the thoracic cavity. But I think that's good enough for basics to know. Let's move on to the direct management and come to surgery quickly. Another study from Amy Kim, results of 53 children with confirmed CLE. And as you can guess, the most common location again was the left upper lobe. I said this 13 times now and warned you about this operation. And if you take a look at that, it's only 11.3% in this study underwent thoracoscopic excision. This saying, I think, again, Sean St. Peter and the Midwest Consortium are those guys that are IPEC, whiz and do's, and they scope anything. Now, if they, that's why I picked this study, if they say that only 11.3% in the Midwest of the United States underwent a true thoracoscopic excision, then you can imagine that what we saw this morning and what must be done in these cases is extraordinary. I think this morning we saw some excellent surgeons, excellent surgery. And again, CLEs, especially when it comes to the upper lobe, this is, even in the hands of the Midwest Consortium, an exception. Good. Before we go into surgery, planned surgery, and I promised to take a careful look with you at the vascular supply. I mentioned that the pulmonary perfusion scan or the CT angiography is very helpful in pointing out the vascular supply, but be aware. In one of my very early slides, I said this is a non-functional lobe. And if that's true, then through the Euler-Liljestrand reflex, the vascular supply that you have to resect later on may be not possible to be imaged, making it very dangerous, because you think there are less vessels than you have, but they still are, of course, will bleed if you do not deal with them properly. So careful. The CLE is mostly a non-functional lobe. The preoperative imaging may not be able to detect the vessels, especially the pulmonary arteries, shut off because of the maloxygenation. And then during surgery, you may get surprises. And finally, I mentioned this study earlier, small study, it applies to CLEs as well. The longer you wait, the more bugs you will get. There is microbial evidence in CPAMs and CLEs, even in young asymptomatic infants, that there is a colonization with sometimes very unusual bacteria. With all of this saying, I think we're ready for surgery. Again, I won't show a movie today because if I would have to show an upper lobe, and those I did openly, but I'll show you a few pictures and come back to the major steps. If you have a CLE in an infant, 2 days old, 2 kilograms of body weight, cardiopulmonary instability, is it wise to go for thoracoscopy? Yes, if you've done 100. Yes, if you have preoperative imaging. Yes, if you know the vascular supply. If you don't, I'm a careful guy. I'm a drainage man, like we heard this morning. So I be careful with these patients as well. I would do an open operation. In the few CLEs that I've seen, I've noticed that the fissure may be incomplete, which makes it much more difficult. And that's why you have to have very careful hook cautery to slowly develop the plane between the lobes. You need sealing devices like ligature or clips. I agree with Giovanna completely that ligature clips are beautiful. She mentioned it this morning for different sealings for the bronchus and the vascular supply. But again, ligature and stapling devices and clips, sorry, will get you by. Staplers are perfect for older children. Bronchial closure, we heard about it this morning too. The bronchus must be clearly identified, and we'll specifically come to the left upper lobe in a minute. Always test inflate the remaining lobes before you finally close it. And I agree again with Giovanna, we heard it this morning. The Hemolock clips are the perfect instruments in small infants and smaller children. And again, if they are bigger, we discussed this morning stapling devices, preferably 5 or 12 now available. Ask Mario and everybody else where these 8mm staplers come from, but they seem perfect. Okay, we talked about the diagnostics. We talked about the definition, the diagnostics, the basic steps of thoracoscopic or open surgery procedures. We're ready for the discussion, open versus MIS surgery for CLE. This is a busy slide, but I'll take you through and I only pinpoint some of the results, some of the most important information. Now, this is a study of 17 years with 45 patients, presented at an early age, 3.5 years. Most of them had the left upper lobe affected again. 9 of these patients had thoracoscopic lobectomy. Operative time no longer than between the 2 lobes. And the conclusion is that lobectomy is the treatment of choice, and thoracoscopic lobectomy seems safe in selected patients compared to open lobectomy. Segmentectomy, I mean, this discussion is old. We talked about segmentectomy with CPAMs. Initially, when I was trained, and this is many, maybe too many years ago, initially I was trained that the CPAM mostly affects the lobe. Then I was trained that the CLE mostly affects the lobe. This is an extraordinary study, one of the rare studies about the recommendation of segmentectomy in CLEs. I just want to mention it, that there is this evidence around, but we definitely need more data on recurrence and complications if we do before we recommend segmentectomies for CLE. 2 more minutes for this talk. We heard this morning that I love this atlas and prepare well for the different lobes, because I believe that a lobe is not a lobe, is not a lobe. You see 3 beautiful cars down there at the beach. It's always a Model T. It's a black Model T, it's a red Model T, it's a yellow Model T, and they all look different, and that's what it is about the lobes. The lower lobe is always the easiest. That's what you see during presentations and meetings. The upper lobe is the most dangerous lobe. It's the D lobe, delicate and dangerous. And I'll tell you why in a second. And of course, the middle lobe is the mastery level. Very rarely that you see those. It's only Rothenberg and a few other gee whiz in thoracoscopic surgery that show these videos and that they master this procedure excellently. Why is the left upper lobe so peculiar? Well, left upper lobe, we'll go into the Gossot and others. Left upper lobectomies are reputed to be hazardous because of the need to control the mediastinal branches of the pulmonary artery, which can be short and fragile, and any tear would cause massive hemorrhage and would require immediate conversion to open thoracotomy. Why do I spend my time with the left upper lobe? Because very simple, I said that the CLE is mostly situated in the left upper lobe. Here are some of my favorite atlas showings again what we're talking about, the anatomy of the left upper lobe, the anatomical landmarks, the bronchus, okay, is anterior bronchus for the lingual and 3 bronchus for the other segments. Lingular, 3 bronchuses. Arteries, most variable. The arterial trunk, which is right there, to the segments 1 and 3. And there are additional, and this makes it so dangerous and so delicate, there are additional posterior segmental arteries. When you go through the fissure and you've seen the anterior trunk, be aware this is not all you get. Yes, you have ligated probably the arteries to the segments 1 and 3, and you will get posterior arteries. And if you're surprised by them, they will bleed as any other artery. And this will be hazardous. So keep in mind, the number of arteries to the left upper lobe varies from 1 to 5, mostly with 2 or 3. Okay. And one final saying, the posterior superior vein is the most anterior element, but it may be split. One of the last cases that we did here, it's an old boy, obviously a huge cystic, huge cyst or pneumothorax, whatever you call it. It's at the upper left thorax. It was mistaken for a pneumothorax. It received outward drainage, and you see the mediastinal shifting already. Selected CT scans of the left upper lobe, obviously this huge cystic lesion, obviously a thorax drain in the remaining parenchyma. The remaining parenchyma, interesting picture, the radiographics of that upper lobe completely different from the lower lobe and the right side. So this proves the point that there's something going on with the function. And of course, the mediastinal shifting. And this is my final and favorite slide of that case. Of course, we did additional CT angiography, and it said by the pediatric radiologist, it is suspicious of no pulmonary arteries. You see the little 3 things here of the anterior trunk right there, but this proves the point that there were no functioning, shut off by the oil strand, and during the operation, of course, you will find them. And one more point to caution. It said suspicious of a common pulmonary vein. So no upper, no lower pulmonary vein separate, but a common pulmonary vein. And just ask me how to deal with that. To make that case short and come back to the final conclusion, we followed, of course, the basic steps. Obviously, we started thoracoscopically. I simply failed, it was a huge lobe, could not develop the fissure adequately, could not get enough safety, could not get enough length for the vessels. Started with the first artery, but that was not good enough. After 2 hours, I claimed myself failure. We opened up and did a careful and straightforward open resection. The results you see here, this is the development of the remaining fissure, obviously a big space. Then you see here the pulmonary arch with a nice dissection of the arteries, keeping, of course, the arteries to the inferior lobe intact. The bronchus is down here. This is what the patient requires. MIS is nice, but this proves, at least I proved that point, that open surgery is not a failure, it's rather success if you avoid complications. So with this, ladies and gentlemen, I hope I could show you some peculiarities of the CLE, being that the CLE has a low prenatal detection rate compared to CPAMs, that the predilection is the left upper lobe, that the left upper lobe is the most dangerous lobe to operate open or thoracoscopically. Neonatals often present with respiratory distress. You then have to judge when to go for surgery. Thoracoscopic resections, even in the Midwest consortiums, the number is lower because of this highest technical demands. Complications, if you fail, may be significant, even life-threatening. We all know that, and it is a mastery operation. openly or thoracoscopically, but especially thoracoscopically, to manage all the skills that we've talked about. With this, I hope I wasn't too boring, and I'll be happy to take any question. And thanks, Giovanna and Mario, for letting me jump in. I'll stay as long as I can, of course.
Olga, congratulations, an excellent, an excellent lecture. And I was really impressed by the image of the Gosso Atlas. I have to say that at the beginning of my experience in thoracoscopic, in thoracic surgery, but also later, every time I have to do a procedure, I put this image
Me too.
in the wall of the apparative room in order not to be wrong, because sometimes I stop and I look at it because it's really very, very, very important. So I have two questions for you. The first one is, have you had some experience of punctioning, I mean, the emphysema when it was too big and it didn't permit to perform a thoracoscopic approach? I know that some surgeons used to do.
Now, Steve Rothenberg recommended years ago that if you go for thoracoscopic surgery and you don't have enough vision during surgery, you may puncture it and release. Absolutely, Giovanna. Absolutely. You're right.
I did just once on the operative theater, really to start, just to be sure that, under radiological control too, just to be sure that it could be possible to enter with the optic without damage and to be able to perform the procedure.
Absolutely.
Anyway, that is not so easy to treat thoracoscopically, and emphysema is the most difficult procedure. And the other question is related to the risk that we have to find blastoma. We know that one of the main association is low emphysema, pneumothorax, and blastoma. So I think when we address this patient to the anatomopathologist, we have to underline that they have to look attentively, because they have to do really a complete serial examination just to be sure. And the third question
again,
is,
let me again agree with you. Of course, especially in CLE patients, we know that the incidence is 1 or 2%. Yes, we see few of these patients, but 1 or 2% for a life-threatening disease like PPBs is too high. And the last patient I showed you was a 16-year-old. So when he is so old, you better examine the specimen very, very careful. Completely agree with you, Joanna. Thanks.
Yes, I totally agree with you. The other question is related to, I mean, segmental emphysema or hyperinflation lesion. We used to see, I mean, hyperinflation area inside the lung of several children. And what is your attitude? Is just to follow this patient, or at a certain time you decide to do some diagnostic procedure or surgery?
Honestly, I'm not yet completely decided pro or against it. My teaching, which now is my gut feeling, says CPAMs or CLEs are lobar diseases. So intuitively, it doesn't make sense for me to just do segmentectomies. And at present, we don't have enough data to prove that in segmental lesions, segmentectomy is safe. On the other hand, I'm very convinced that Steve Rothenberg and Michele and Mario and you, we could do segmentectomies to preserve healthy pulmonary tissue. So maybe in a couple of years, the next generation will be able to do both segmentectomies and studies. But for the moment, I'm very careful. Why not be careful? See, when you do a lobectomy in a 1 or 2 year old, we know that the lung grows until the age of 4 years. And we know that by the age of 4 years, so 2 years after the operation, the cavity is filled with healthy pulmonary tissue. The pulmonary function tests will not reveal any diminished scores. So preserving pulmonary tissue that may require another operation is not as necessary in these young children, and that's a privilege that we have as pediatric surgeons. So I would do it. I would play it safe at the moment. Lobectomy.
Yes, I think I mean, many pediatric surgeons, the most number of pediatric surgeons prefer to perform a lobectomy because it's safe and because they think that the lobe can have the lesion also not visible on the side. And the other thing is that if you do surgery very early, obviously there are no damage for the patient. That are really two arguments. So I would like to say good afternoon, not to you, but to Paul Philippe. Paul, I know that he has reached us recently. Paul, could you hear me?
Yes, I can hear you. Can you hear me?
Good afternoon, Paul.
Okay, I just joined. I'm just falling and I hear the discussion about segmentectomy.
Please give your advice, please.
I like to do segmentectomy because many of those lesions are quite small and quite limited. Of course, the big ones, there is no doubt. But now we can operate on smaller lesions that have been seen antenatally. And it's an anatomic resection too. Against the arguments that were quoted. One, yes, there can be anomalies in other parts of the lobe, but also in other parts of the lung, and even on the other side. And we cannot remove it. So taking a lobe is not necessarily 100% guarantee that you will not have abnormal tissue elsewhere. About the compensatory development of the lung. Unfortunately, to the best of my knowledge, there are no count of the alveoli in the lung after a few years. As Olga said, we see that the lung develops, occupies the whole space, gets the same volume. We also know that the function tests in the future are within normal limits, but we know that those normal limits are extremely wide, between 70 and 130% of the mean, which is one of the largest values, spectrum in what we call normal. So I would put it the other way around. Why remove healthy tissue when we can anatomically, safely limit the resection? It is quite easy in the lower lobe to do a pyramidectomy or a Nelsonectomy. In the upper lobe, dividing the segment on the right is not easy, but on the left, doing either a lingulectomy or a culmenectomy are very anatomical operations. And I think that we should at least consider them because why remove potentially healthy tissue? There are very few reports about the risk of recurrence and the need to reoperate on recurrences. And that's even more so if we consider that there is even a European study on on small lesions, should we operate on them or just observe them? So I have done probably 15 segmentectomy. I have one child that has a residual that is about like this. I'm just going to observe him because of those reasons.
Thank you, Paul, for your competent advice. I think we can give an answer to this question, sparing surgery or lobectomy in 20 years. If we will be able to elaborate a register of this patient, in this way, we can maybe we can give some available and answers. That means, how is the function in patients submitted to lobectomy and segmentectomy? What is the incidence of recurrence? So I think it could be very interesting to be able, as a European pediatric community, to elaborate a prospective study on this field. Not only a prospective study of conservative versus operative. I think we will not obtain any results because we have several studies that demonstrated that there are complications waiting for surgery also in asymptomatic patients. But the evidence is not so high. But what could be really important to obtain some evidence is to have a prospective study between radical and sparing surgery. That I think it could help. I would like to thank again Holger. I know that he has to go to the theater. Thank you very much for helping us also today and for giving your expertise to our meeting. See you soon, Holger. I think we will see in Miami soon.
You bet. See you in Miami.
I hope so. I hope so.
Oh, yeah. Oh, yeah. See you soon, Joanna. Bye-bye, everybody. Thanks.
Bye-bye. Bye-bye, my dear. So now I think maybe Mario is ready. Mario, could you hear me? No, no answer. Mario? Yes, I don't hear you very well, but please ameliorate your audio. Okay.
You see?
Yes, we are seeing, but the audio is very low.
The audio is low. Yes. Now it's better. Now
Little bit. You have to augment more.
It's better now, the audio?
Now, yeah, now it's possible. Okay.
Okay. When I put inside the other two trockers, Dr. Dimitri show you the cases, okay?
Okay. Okay, Mario.
Yes, we are ready to your young colleague.
Poca roba, aspetta però, aspetta. Mi dà allora i tre, forza, il trocker.
Please, Thomas, where are you? Oh, Dimitri, it's Dimitri. Okay.
Can you see me?
Dimitri, go on. We are able to see you.
No, il 5 me lo dà sulla destra. Sta facendo Dimitri? Non sento un cazzo, perché togli l'audio?
Do you listen to me? Okay.
Yes, now we can listen you.
So, I'm presenting the clinical case of an infant of 4 months of age with an intralobar left pulmonary sequestration that we are approaching for a thoracoscopic resection. These patients had a prenatal diagnosis of intralobar left pulmonary sequestration made by prenatal ultrasound and confirmed with the fetal MR. So he was followed at another center and during pregnancy, the MR done at 20 gestational week age showed a pulmonary mass of 22 times 22 times 19 millimeters at the lower lobe of the left lung, with the feeding artery originating from the thoracic aorta. So at birth, the pulmonary mass was investigated by a CT scan that showed more clearly, as you can see in this picture, the pulmonary mass with the originating vessel from the thoracic aorta. Thank you for the listening.
Yes, we are listening from you. And the picture looks very well and they are impressive.
Yeah.
So, Marco, Professor Lima is planned to start in thoracoscopy and then to convert to open surgery.
Yes, we will see if it's possible by thoracoscopy, and after we will decide if make a thoracotomy.
Obviously, very well. I think it is not the case that I show it today in terms of high pressure vessels, systemic vessel coming from the aorta. So it's a dangerous case. That's true.
So
but,
we will see.
I agree that maybe Mario is able to manage in the thoracoscopic way too. He's very expert. So we will see.
Okay.
I would like to ask the Regia to move to the operative theater. Mario, could you hear me?
Yes, and you?
Yes.
Yes, very well, Mario.
So we have seen the case presentation, which is a challenge, complex case with big vessels, high pressure. So I think, but I am confident that maybe you are able to perform thoracoscopically. So we will see. It's, you know, Paul Philippe is with us. He has already given his advice on
Guardate l'immagine esterna. Please, Giovanna,
yes.
I show you the external field.
Yes.
You see the external field?
Yes, yes.
Okay, this is the position of the trocar that I use when I do a thoracoscopy for operative lung surgery, because I use 5 with balloon for the lens, 3 millimeter in the mice left hand, I don't see the image, and in the right hand 5 millimeters that I use for instrument of 3 millimeters. I change this, or 5 millimeters, and it's possible to use here the ligature or the stapler. Okay, now go inside, please. Un'altra fenestrata.
You have a good vision of thoracoscopic? Yes, it's good. Okay.
So
This
very
is the inferior lobe.
The two lobes.
Yes.
Madonna Santa.
And here we have the sequestration.
Poi te lo dico perché sto usando.
This is the artery, okay? And this is the sequestration. You see, because is 2 centimeters for 2 centimeters. We start and prepare the artery. Dissettore, per favore. This is a very good spot for Karl Storz. Puoi mettere a fuoco, per favore? Secondo me non è a fuoco. Puoi mettere a fuoco? A fuoco? La telecamera a fuoco. Per me non è a fuoco, o sono io che ho gli occhi messi male. Oh, finalmente. I think now you see better.
Yes, we see better.
Because it's the problem of the focus.
The artery is very clear on video.
Now I use 3 millimeter instrument. Prima dobbiamo chiudere sta roba qui.
Sì.
It's important to pay attention to the back isolation, because the problem is if have another vessels. Mi sfidi il trocar di sinistra, un po' il trocar di sinistra. Grazie.
Yes.
C'è la pinza L da 5? Sì. Va bene, va bene. Mi prepara le clip. Un altro dissettore a sinistra. Un altro dissettore a sinistra da 3. Dammi la fenestrata, per favore. Torno indietro. Mi prepara la clippatrice, per favore. Torna indietro, indietro. Gommino e clip. Ho bisogno del gommino. Se lo monta sulla cosa. Metti pure.
Sì.
Prego? Ah, sì.
Mario, can I say something? Why do you prefer to use the titanium clip, which are not always so safe and not Hemolock? I know that you're expert, but
because I use the clip.
Yes,
I
because use the titanium clip, not other, not polymeric, for example. I know they are smaller, so they are easier to be placed.
Because I use always this, and sometimes now I won't see that don't have hemodynamic change because I closed the vessel.
Yes, I agree with you.
And I stopped it 1 moment. Remember, this is important because if you is not in correct place, now it's possible to return, to remove the clip.
Okay.
If you cut,
yes,
it's impossible to return.
That's true, that's true. Also,
anesthesiology is quiet, don't have problem. And I slowly go away. Dr. Libri remember and say me that I prepare the clip because you see open well the branch. Probably I have 2 vessels, you see. The aorta is here. And I put the second clip, the proximal second clip in this place. Giovanna, do you agree?
Yes,
Giovanna,
I agree
I
always.
go. Okay.
No, it looks very nice, I have to say. Looks very nice. I feel not so confident with the clip, but you have put it so well, and you are right. If you put clip, you can remove.
I leave 2 clips.
You can't remove.
I leave 2 clips here, 2 near the aorta, and I cut here. Now, it's possible that we see very well the demarcation of the sequestration. You see, this is good lung. This is lung that anesthesiology because puts inside a blocker, but this is lung. This is the sequestration, and here you see finish the sequestration, and here we have a good lung. It's okay? You agree?
Very evident the difference between the devascularized part of the lobe, which
now I cut the vessel. Forbice, per favore. No, da 3. Cos'è quella da? Con il gommino me lo deve dare infilato.
Vuole il gommino da 3 perché la sostituisce con qualsiasi.
Non c'è bisogno che ecco il dito, devi solo mettere quello velocemente perché c'è una valvola sotto. Vito, you agree what I do?
Absolutely, Mario, absolutely.
If you don't agree, say me, please.
Ah, no.
The problem is the scissors don't work well. Va bene, va bene. The position of the clip is good because I cut the vessels, but don't have bleeding. Prepari il ligature. This is the advantage of the trocar that I show you before, because it's possible to use 3 and 5 millimeter. Now I use the scissors that work well. And now I use also the ligature. I want to see if we have 2 on or 1 vessel.
Okay.
I think it's a 1 big vessels. You agree?
Yes, there is only one big vessel arising from our thoracic aorta.
Uncino da 3 millimetri. Now I prepare
the inferior lobe.
Okay. Now I mark exactly what is where arrive. When arrive the good length and when arrive or finish the second. You see, if you agree, say me. Oh, if you don't agree, say me again.
So Mario, do you perform sparing surgery of the lower left lobe?
Yes, I don't touch, I don't remove, because this is a sequestration. I won't show you
I have to
sparing
say
surgery.
it's not so easy to do sparing in interlobar sequestration, but nevertheless, you were able to have a clear difference between the 2 parts of the lung. This
is the sequestration, and here we have a good lung, and here you have the sequestration. Stai un po' più lontano. I do this because after, when I use the ligature for the lung tissue, sometimes don't you see very well what is the good and the bad tissue. Mi sfila un attimo il trocar da 3. Sfila un attimo il trocar da 3, stai lontano. Stai lontano. Ok. Vado qui con il ligature. You see the
Yes.
this is the limit. Okay.
Mario, have you seen if there are vein to return?
Now I go slowly with the ligature and I expose the vein.
The
Okay.
vein, okay.
Mi dai ligature, per favore? Cominciamo.
Mario, sorry. So you are proceeding plane by plane from anterior to posterior.
Yes.
To identify the aberrant vein.
Yes, I go slowly. I open the upper part, okay. Here. Bisogna allontanarsi perché secondo me è venuto fuori. Un momento c'è. Ok. Bisogna avere dei problemi. Ok. Pulisci. Pulisci l'ottica. Può avvicinare per favore la colonna e così la vogliamo mettere. Fammi vedere. Ora non vedo niente. C'è anche quello più lungo di ligature, per favore, perché io non riesco a lavorare qua. Il Maryland, su, mi dia il Maryland. Cambi subito perché questo è troppo corto. Sì, va bene. Ma il problema è che mi sbatte qua. Vabbè, non è un problema. Se io ce l'ho qua, lavoro. Sì, può essere. Attenzione, scusami. Vado? È una vena. Vito?
Mario.
You see, this is the vein.
Okay, I see. My question is, at this point, it's better the use of endogia?
It's possible, but you see in the good lung, the pneumostasis is perfect.
Okay.
Now this is the point, I think, where there is the vein.
Okay.
The drainage, you see?
Yes, I see very well.
I go here, I sealing, and I cut.
Okay.
Okay.
Fantastic.
You agree?
Okay.
Now I check whether this is really is the vein, because this is the distal vein, you see?
Yeah, no, yes.
And this is the proximal vein that I check with Dr. Libri that helped me, stayed me in the hair. Check please the back, because I won't see the clip. No, okay. Okay. Here we are. This is my plan.
Okay. Yes, this is the section plane. It's very easy to view at this point.
I go slowly, because if you go slowly, you go safety. And this is important. Okay? Probably we are near to the clip, and I stay. Fammi vedere il picture. Okay. Here is good. You agree, Vito?
Assolutamente. È il peduncolo questo, il peduncolo venoso.
If you want, say me in Sicily language.
In Sicily language?
Yes, if you agree.
Oh, mi pare perfetto.
Now it's possible to check if you have removed all sequestration. For the dimension that I know through the TC is the same, is 2 for 2 for 2. Okay? And this is the lang. The good lang, please, I won't see here. Okay. Okay, you see? The question is, you want to put inside a stitch or not?
Or not.
I think that is not fundamental to put inside a stitch because the resection is peripherically. And I use the ultracision. You agree? Giovanna, what you think? Because Giovanna, there is no, okay. Here we have the clips, okay, and the vessels. You see? Now I remove and I show you the final situation.
Professor Lima, a question from Michele.
Michele,
Do you use sometimes the air sealing product?
No, I don't use. I use only one time and I have a complication.
Really?
The eye of the lung create a big bubble.
Okay.
With the sealer.
Okay.
And I have a problem. And
Okay.
for this reason, probably I don't use well high. You use the sealer?
No, but the company showed me. Yes, I used just once for demonstration.
Okay. I hope that say that I use, because I don't use. I use one time and I have a problem.
Okay.
And for this reason, I don't use.
Okay.
If I may, in Luxembourg, I have used a few times NeoVeil, which is a film that you put on the lung surface, and we never had any problems. But the truth is we never had problems without it either. And to fix it in the right place and correctly, it's not very easy. So we have used it several times, but we didn't find any benefit from doing just nothing as you have done, Mario. It was a very nice operation and congratulations.
Mario was really very nice. I apologize because I was obliged to follow some problem in the department, but I followed all the surgery and it looked really very well.
This is the difficult part of the operation, to remove without. Mi dà per favore un'anatomica? Grazie. No, perché è troppo piccolo il bambino. Un'altra anatomica. And it's possible to remove if you turned the tissue. This is the technique of Giovanni Ruggeri that I think that is connected, Giovanni, because I see that you are right. and this is the sequestration. I have removed a little part of good lung, you see, but all is the sequestration. Now I come inside, I won't check the bleeding, I won't check the clip, and I leave a drainage for the same reason that we say with Valerio, that we clip the vessels and it's possible to have a bleeding. And also in the laparoscopy remove with sparing surgery, it's possible to have another that is possible to have gas and remove area. Mi dà per favore l'aspirazione? Ok. This is the side. Prima le due fenestrate.
We don't have the view of the thoracoscopy. We have the external view. Good, thank you.
Okay. You see the internal part, okay? This is the clip, aspiratore.
Mario, do we still see the clip on the lung side? And shouldn't you remove another centimeter there so that the clip, which is the inferior limit of the sequestration, would come out, that bluish part of the lung? Don't you think it should come out too?
I want now, Paul, good morning. I want see well, really, and decide if to remove this little part.
Yes, I think it's important, the suggestion made by Paul Philippe, if there is some amount has to be removed. But the other lung looks fantastic. It's not affected by the sequestration.
Voglio vedere una per decidere. Fammi l'altra. Leadership. Certo. Sfilo il trocar. Quello bianco. Mi tornano in campo le altre clip. Stai più indietro. Che problemi hai? I stopped one moment because... Niente, tira fuori. Puoi anche mollare il coso, il bloccatore. Infatti funziona bene. Sì, adesso aspetta un attimo. Gas. Riparte con i gas. Vabbè, non lo vedo. Ok, va bene, va bene. Okay.
No, scusi lei, dottoressa, non so dove mettere i piedi.
Da pulire. Now it's possible for you to see the difference because before I work with blocker and now I don't have the blocker. Altra finestrata. I don't know if remove a little piece because back there is, dovresti però usare meno pressioni se riesce. Se riesce. I asked to anesthesiologist if it's possible to use lower pressure because don't have the blocker and we have the problem with the lung. For the sparing surgery, it's important to have a good blocker. This is a spot for anesthesiologist. Really, the little piece is very near to the artery, and I think I don't remove because it's clipped and don't receive blood, and is same if you use the embolization or sclerotherapy. I put inside, one moment. Give me the suction, please. Please, Monica, increase slowly the pressure because I won't see if I have problem of with the lung, if it's possible. Is a little, very little, but we have now high pressure that is not the pressure when arrive in intensive care. There is no problem. Stop it, thing. Grazie. Prepare, please, the drainage. No, io li voglio buoni. Ah, sono i buoni. Ok, quello lì. È una cosa minima, quindi Mattia avevi delle pressioni molto alte, no? Adesso siamo a posto. Ok. Okay, I put inside the drainage. I remove this. If you want to use the same scar of the trocar, don't forget to go in the upper part for the trocar. Riesci a vedere?
Adesso te la do, Francesco, non ti preoccupare.
Riesci a vedere? Io sono sopra, dovrei essere sopra perché questo è quello dritto. Ok. Fermo, 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 per favore. Okay. Sì. Non crampi niente, per favore. Ok. Lei sta assistendo. Ok. Via il trocker. Via questo. Avete preparato? No, no. Okay, I have finished. If you want to see the external view. You have the external view?
Yes, Mario, we see better. We see better.
This is, I use the posterior for the drainage and close the two scar. If you want, now it's possible to have a little break and restart 2:30. You agree, Giovanna?
Okay.
Yes, yes, we agree. So we solve some clinical problem.
Okay, thank you very much.
Thank you very much, Mario. Congratulations.
Bye bye.
A very nice procedure.